everyone as you start to arrive. Hi, good morning.
Morning.
Hi, everyone.
Morning.
Hi. Nice to see everyone.
Morning.
Hi. So we've got a minute till we start. I'm going to do a register first so that I keep Thomas happy in the office. And what we'll do as everybody arrives, I'll just start at the top of the register and work down in a moment. And so just a little, when we do, check you all off, and just a little bit about you and where you're from, and maybe a little bit about what you know about hypopressives, if you know anything, to give me a kind of overview of where you're all at. That'd be amazing. And I, so I'm Abby Lord, and I'm a master trainer in hypopressives. I am also a personal trainer. I am also a somatic movement specialist. I have years of experience of working with pelvic floors now, like almost 12 years of working with pelvic floors. And I don't think there's anything I haven't seen, literally. And there's probably not a question that I haven't been asked. So if you have questions about anything to do with pelvic floors as well as we go through, please just feel free to ask. I've been coaching hypopressives for 12 years, and as a master trainer, coaching and training other trainers. So sometimes if you can't unmute, come back in and go out and come back in. Is what I was going to suggest. Training other trainers for about 7 years now. Yeah, probably about that. Okay, and I am on demand around the world, which is quite freaky. And I also run my own studio here with one-to-one clients and online clients. So I guess that's an overview. And I've also done all my Pilates training with VASI, but I haven't actually passed it yet. So I have some idea about Pilates, but I'm too scared to do my exam. Although Lisa keeps telling me just to bloody do it. So, So I've got quite a lot of experience there, and I'm also just training just now as a TRE, which is trauma therapy or tension release therapy provider as well. Cool. And somebody else is dropping out and we'll be coming back in. So that kind of gives you an overview of me, I guess. And I've got 2 kids and they've both been really problematic this morning. So I'm a bit like, I'm just calming down slowly. They're teenagers, almost, both of them almost. So it's a new world of hell. I know, Vanessa, I know. It's just a new world. It's just a new world of hell for me. But also beautiful.
I'm not even there yet, so it's just a stage I'm not looking forward to.
One of mine's 13 and one's 11, going on 16, and he's the worst one, to be honest. However, we will get through it. So today is all about hypopressives. We're going to be doing the foundations. So I'm going to start you off right at the beginning. I'm going to tell you a bit more about that once we've met each other. So I'm going to start with the top of my list and just work down. So Sue Napier, you're at the top of my list. You'll need to unmute.
Hi there. Hi. So I'm Sue. I'm up in Saddleworth, which is near Manchester. I've been teaching a long time, and I'm always interested to know new techniques to bring in to freshen up my teaching, and particularly pelvic floor. Yeah, that's an important thing, I think. So yeah, that's why I'm here today.
Excellent, Sue. Lovely to meet you. Brilliant. And I look forward to having your input as well, because this isn't just a one-way street. Well, you might find things you go, oh, or you might be, ooh, I'm not sure. So just do feel free to ask questions. I'm a person who I like questions, yeah. They inform my teaching as well. So lovely to meet you. Wendy Gill.
Hello.
Yeah, you've got to accept the fact that, Wendy's on here to everyone. Have you accepted the fact that, Wendy, you're doing well? You're giving them all advice.
I couldn't get in either until I accepted it, and then it all opened up. So
yeah, it's being recorded, because in a moment I'm going to pin me, and then that way I can send you a recording just of me with nobody else on it. So you get a recording after this. So you don't have to take masses and masses of notes if you don't want to. You can just be in the moment with the course. So yeah, I'll take us off gallery. I'll put you back on gallery, but I'll put me pinned for you guys, and then you can choose what you do with your screens. So yeah, if you accept the recording, it doesn't mean that you're going to be recorded post this, because I will cut this first bit out before I send the recording out to everybody.
It's just that when you come in, because
Yeah.
it's recording as I came in, and then I couldn't turn my camera or my sound on, and I think that's what the other people are having trouble with.
Yeah.
So if they accept, because there's a button somewhere that says accept recording, and then if they do that, then I think that it should work, if it's the same for me anyway.
I think it is. I think that's what's probably going on.
Yeah, so I don't think that we can see or hear them because of that, but they can see and hear us.
Sorry, guys.
Hey!
Yay!
There's one
There's
in.
one in. There's one in. We're just going to wait for Sue. So Sue will work out now, I think. I just love this online world.
I know.
So I guess, Wendy, since I said your name and we start talking, I'll get you to introduce yourself next.
Yes, hello. I am a teacher up in the north of Hampshire, just north of Basingstoke, and I've been teaching for 8 years now. And I have a bit of experience of hyperpressives only for myself, because I had 3 babies in quite quick succession with a bit of repair work, and then everything was quite weak. And after a few years, I felt like I was prolapsing a little bit. And I looked around kind of on the internet, because I didn't really want to go to the doctor about it, and came up on hypopressives. So I went to a local chiropractor who is a hypopressives teacher, and just did a couple of sessions with her, and I think I practiced it every day for about a month, and it completely sorted everything out, and I've never had a problem since. So that was about 5 years ago. So it was absolutely amazing for that kind of thing, just drawing everything in. And as a byproduct, I had kind of 2 fingers diastasis recti from being pregnant, and that brought it all in as well. So yeah, it was great. So I think hypopressives are great, but I very occasionally use it, but not very often. So I just thought that it would be quite interesting to find out just a bit more about it.
Excellent. It's also quite interesting for me. Did you do we'll talk about it when we come to it. So there's 2 different schools of hypopressives in the UK just now. There is UK hypopressives, and then there's what low pressure fitness and the IHC teach. So the breath work's slightly different. So I'll be interested, Wendy, after we've done today's session, to hear what you think, because I suspect you did a UK hypopressives type of breathing.
Hopefully,
I
can.
No, so it'll be good. So I'm not going to say anything just now, because I would like to see what you feel about the differences before I coach you in it, yeah, so to speak. So nice to meet you, and I'm glad you've got great stories about hypopressives too. I have so many great testimonials from women and men, actually. We're going to talk about them too, don't worry. So next on my list is Caroline Bishop. Is Caroline here?
Yeah. Hi.
Hi, Caroline.
Hello. I'm in Hitchin in Hertfordshire. I'm quite newly qualified. I've only been teaching just over a year. But I was really interested in this because I've had 3 children as well. So I've got a 10-year-old, and then I've got just turned 5-year-old twins. So yeah, and it's something that my sort of pelvic floor issues since then has been something I've been meaning to get a bit of a handle on, but never really have. And so reading about this and Abby, a little bit about sort of your experience and how you got into it, I thought was really interesting. And also just one of my teachers does a lot of fascia work, which I really enjoy. And so that was something I really wanted to learn a bit more about as well. So that's why I'm here today.
Brilliant, excellent, nice to have you. And I'm also interested to see how you find hypopressives for your body as well as we go through. Brilliant. So, Rosalind, you're next. Rosalind. Ros.
Hi, yes, yeah. So I've been teaching for about 19 years now. I don't know anything about hypopressives, but I do always put a bit of a pelvic floor focus on my classes. I'm always talking to them about it. So I was just super interested in this. So yeah, so I'm really looking forward to this course. I can't wait.
Hey, so just no pressure.
Yeah, no pressure at all. Yeah.
Pressure. We'll see how. I hope you really enjoy it. So it's a slightly different take on pelvic floors from usual pelvic floor work.
Yeah.
So we're going to look at the whole body, which is always good. So yeah, nice to meet you, Ros. Brilliant. And next is Emma Lee. Emma. Oh, there, down the bottom.
Hi. Yeah, that was great. Thanks for the tip about accepting the recording, because I was stuck in video without video. Yeah, I've been teaching for 24 years with BCPA, and did I trained with Alan Herdman about 12 years ago as well, and I've just completed TRE training.
Oh, that's what I'm doing just now.
Yeah, it's great. Are you in Brighton?
No, I'm in Edinburgh. So
You're in
I'm well
Edinburgh.
near Edinburgh, East Lothian. So yeah, yep.
Okay, great. It's fascinating, isn't it? It's really amazing stuff. And I'm a Buteyko method breathing instructor as well.
Amazing.
Yeah,
I just do that for self-practice. So yeah,
yeah, fantastic.
next on my list.
Yeah.
It's a long list. Well, lovely to meet you. And yeah, it'll be nice to hear how you're getting on with TRE at some point too.
Yeah,
So
thank
to
you.
connect with other practitioners of weird things.
Yeah.
So lovely to meet you. Okay, so next on my list we have got Sally Parker.
Hi.
Hi, Sally.
Hi, I'm teaching down in Cornwall. I've been teaching for about 24 years as well. Seems an awfully long time, amongst other things. What is TRE?
It's tension release exercises. So it's to do with releasing the body's own natural tremor response. And it's to unwind the stress out of your body. You do a series of exercises first to fatigue the body, and then we bring you into a tremor response. It's to do with the whole natural experience of, but it's to do with polyvagal theory. It's to do with our body's own natural response to stress. So usually when our body's under stress, naturally we'll start to shake. And what we do in society is we coddle that. So we you know, if somebody's had a car accident or something, they're shaking, we wrap them up and we guardian them, instead of allowing their body to kind of release the tension from the tissues. So it's about, but it's just always about the tiger in the room all the time. You know, there's always a bad phone call or a bad experience with your children, or, I mean, there's always something. And what we do is we just keep it all inside. So it's about finding ways to release that. I'm just training. Emma might have something else to add to that.
Yeah, it's a natural mammalian response. When you look at animals, when they've been chased or they've done the chasing, they will generally shake it off at the end. So they release the chemicals, the adrenaline and cortisol needs to work its way out of the system. And it's a natural way of them resetting back to, if you're looking at their, you know, them on their central nervous system, their scale, it brings them back down to that more rested and less, you know, vigilant state. So yeah. Yeah, that's it, I think.
Yeah, so basically it's for me, when I'm working with women with pelvic floor issues, the reason I'm doing it is because most of the women that I meet with pelvic floor issues are in a real stress response or in a real dorsal vagal response. So they've either completely shut down or they're completely all the time, which is kind of where I was a lot of the time. So it's about bringing them, getting all of that worked out through their system so they can come to more of a ventral vagal state. So it comes from polyvagal theory as well. So I'm always sending women off for counselling and to chat through their trauma, but I think sometimes talking through trauma re-traumatizes. So it's nice for them to be able to just work it out through their body, and then when they do hypopressives, it's even more effective. So that's kind of where my journey's taken me to that. Yeah. It's amazing.
Yeah, sounds really interesting. I'd like to learn more about that.
Yeah.
I saw you at the Body Control Development Weekend. In fact, I did 2 of your workshops there. I don't know how that worked, but they were very different, so that was good. And I have 2 daughters. One's an osteopath, and the other one is another Pilates teacher, who are both about to do hypopressive courses, and said to me, "Tell us what it's like, Mum." So I will.
Yeah, good.
So
good.
yeah, I'm really interested.
Well, it'll be interesting because if they're doing the course with UK Hypopressive, the breathwork is very different. So yeah, we'll talk about that, because I always like to talk about what the other schools are teaching as well, just so you can try both, and then you can see which one's the most effective for you. Yeah, Okay, so Sally, we are moving on to Helen Stewart.
Hi. Sorry if it looks like I'm not looking at my telly. I've got my webcam on, and then I'm looking at my telly.
Yeah,
It just
go
looks like I'm ignoring everybody, and I'm really not. So I'm just looking at my telly, but my webcam's picking me up. I'm from the Midlands, so I'm from Newark. Been teaching about 10 years. And I know kind of the normal amount of pelvic floor stuff that we do in Pilates, but I've got quite a lot of people coming to me kind of asking for help specifically with pelvic floor stuff, and I'm having to refer them out everywhere, and I'd like to just have obviously a lot more experience and a lot more knowledge on what I'm talking about, so I can kind of bring it in a little bit and maybe then run specific courses for them rather than just kind of pushing them off to other places.
Perfect. Perfect, good. So these 2 days should really help that.
Yes,
I'm
definitely.
I'm hoping these 2 days get you to a stage where you start to really practice and try it out on people as well.
And then wanting to do that exam as well.
Brilliant, good, excellent. I'm having to, I'm writing the multi-choice online thing. I might have to just have a day where we have a test on theory at the moment because I'm terrible at writing online like multi-choice things. I'm like that. Yeah, but we're getting there. The exam, brilliant, good, excellent. Nice to meet you. And then I've got Vicky Bush. Vicky.
Hi, yes.
Cheers here. Vicky there.
Hello. I'm based in Cheltenham. I've been teaching Pilates 8 or 9 years now. I'm quite interested in hypopressives. I've only heard about it recently, but my daughter's got an 18-month-old child, and she lives in East Lothian, and she did hypopressives as part of her pregnancy. Sort of.
Who's your daughter?
She's called Ruth Bush.
Ruth Bush.
Yeah.
She must have done it with one of my trainers because I'm in East Lothian.
I know. So I wondered. It must be something in East Lothian because I'd not heard of anyone doing that before.
Yeah, so I started in East Lothian, Vicky, but I've trained quite a few yoga teachers and things around here. So it'll be one of my trainers because I was the first one in Scotland. So one of my ladies. Yeah, how cool.
But my clients are sort of much older than that in general, and I just think hypopressives also would be very useful for people who are older, you know, sort of maybe given birth a long time ago and perhaps had prolapses, I don't know, but you know, just in general health, I think, and toning. And I'm also quite interested in the fascia aspect because I go to a class for the MELT method. I don't know if you know that.
I do know Sue Hitzman's the MELT method. I do indeed. Yeah, a lot of my foot stuff is from Sue. Yeah.
Yeah, I really like that.
Yep. Yeah, it's good. So the fascia stuff that we're going to do is very much about, well, we'll get there. We'll get there when we get there. I'm terrible for that. I'm like, let's tell you everything now. So, so we'll get there. So I hope you enjoy it and ask questions as we go. I wonder who taught your daughter. I'm intrigued now. So Alison Driscoll, you're up next.
Good morning, everybody. Teaching 20 plus years, too many years probably to think about. And I'm based in Cockfosters, which is Hertfordshire, outskirts of London, really, end of the Piccadilly line. I looked at this course when it came up on the newsletters from BCP. It's just grabbed my attention. So I'm really looking forward to today. I think we do pelvic floor work naturally in our Pilates teaching, but I'm really interested to find out more about this subject. So looking forward to today.
Excellent. Again, no pressure. Nice to meet you. So then we've got, is it Yoiti?
Yes. Hi there, Jotty.
Jotty.
Hi. So I'm also in Scotland, in Edinburgh.
Are you? Hi.
Yes. So it's sunny here. It's amazing.
I know it's been dark for months.
So I've been teaching, I think, for about 15 years. And I didn't know anything about hypopressives until we got the email from Lee about the course. I just thought it sounded fascinating. And like some of the other people have said, it would be great to kind of have a bit more knowledge about pelvic floor and things I could help clients with, probably on a one-to-one basis. I'm thinking it's more appropriate. Just really interested in finding out more. And personally, breathing anyway, I always think I'm not that great at breathing. don't breathe that deeply. So it'll be interesting to see, just to learn about it.
Excellent. And yeah, you can come out and see me and everything. So
can.
that's amazing. I'm just 30 minutes away. It's like brilliant. Good. And I get loads of ladies wanting somebody in Edinburgh, so that's even better. So yeah, good.
Could be good.
Yeah. Whoop, whoop. Win-win. So next we got Sue King. Sue's got an old computer, she says.
Hello.
Hi, Sue.
Hello. Yes, I've got an ancient machine here with no camera, but I am smiling and joining in. I'm really happy to be here. So just imagine there's a smiley face. I've been teaching for about 8 years. A lot of my clients are interested in this sort of thing, and I think I'm really fascinated just to learn more about it, because I think when we did our training there was a lot of focus on pelvic floor, zipping up and all of that, and yet now there's an awful lot of actually don't think about it, relax, make sure you switch off, and so it's a bit confusing, so anything we can learn will be brilliant.
Excellent. Yeah, we'll talk about the zipping up.
Thank you.
Yeah, that we'll do an overview of that. Lovely to meet you, Sue.
Thank you.
Nice to have you here. And then we've got Anne-Marie Hume. Is Anne-Marie here?
Morning, everyone. Hi, I'm up in Inverness, another Scots, and it's sunny up here too, a rare day. So I've been teaching. I've actually just turned 20 years teaching with qualified with BCP, and I've been fascinated about the fascia for quite some time now, and looked into some myofascial release courses. I've done a couple, and I'm just really intrigued about the inner core. It's just fascinating to me, and anything else that I can learn for myself and my own body. Like Jyoti, I'm aware that I probably quite often not. I could probably drop the probably, hold my breath from time to time and things like that. And again, just life journeys, having children. I'm just curious about how it could help me with regards just my own inner core, but I'd love to look at how I could proceed forward and maybe do the training and start to offer it out to to lots more people. That's how my Pilates training, I couldn't get over how much it helped me, and it inspired me to go and teach. So looking forward to whatever journey unfolds from it. But thank you for running the courses. I'm really excited about it. Yeah.
Ace, I'm really excited about the spread of where you're all from, because I get inquiries from people wanting in-person people all the time. They don't necessarily want online. So the more we've got people across the country, the more I can just refer people when they find their way to me. So yeah, which is brilliant. So, and Inverness, there's not a lot for anybody up in Inverness except the weather. Yeah, I like it. I like the Schneck. There's some good pubs as well.
There are.
There's some great music.
Yeah.
So, Anna Hargreaves, you're up next.
Hiya, that's me.
Hi.
I'm based in a place called Wallington, which probably no one's ever heard of. It's like sort of southeast London, Surrey borders, near Croydon, which is nice. And I've been a teacher for 3 years now, and just sort of more latterly been really getting more interested in the power of breath. Seen the hypopressives for a few people that I follow online has become a bit of more of a buzzword. And one of my girls that I actually trained with, I think she's doing your course currently, Abby, and she's having great results for herself and also the people that she's having to work with as well. Most of my clients are my age or older. Most of them have had children. Some have had to have surgeries already. So yeah, just interested to see how we can help ourselves. And I don't think that, pelvic cord and prolapse is something that we should just have to accept and live with.
No, it's definitely not. Who's that? Who?
Jackie Canado.
Oh yeah, she's brilliant.
Yeah,
She's brilliant. Yes, Jackie. Yeah,
she's
she's a really good trainer. She's really, really good.
Yeah.
So the whole idea that we should just accept this because we're aging or because we've had babies or and this is normal. It's not normal. It's common. And all of these issues that we're going to talk about are common issues for women, but they're not normal issues, and we can do loads about it holistically. And I think that's the biggest thing is that women are oftentimes just referred to surgery or told to just carry on with their normal lives and we'll fix it when it's broken, properly broken. There's no
and then
point
your
fixing
self-esteem and dignity is usually shot to pieces by then. So yeah.
Yeah. And also there are things that you can't do after surgery. There's like, you can't lift anything really heavy. You can't, you know, there's so many caveats to surgery, and we want women and men to come back to being really functional in their pelvic floor, so that they don't have any caveats. They can just go and just do it. Yeah. So that's kind of where I come from as well, Anna.
Cool.
Cool. Nice to meet you.
You too.
Yeah, I've not heard from Jackie for a bit. I might drop her a line. And Georgia Brown.
Oh, hi. Hello. I'm in Amersham in Buckinghamshire. I don't know anything about hyperpressives. I'm a completely blank slate, which I'm hoping is a good thing. I do a lot of teaching for low back pain. So I think in the blurb, it was mentioned it can be helpful for people with back pain. So that caught my eye. That's why I thought, well, this could be good. I get a lot of physio referrals saying this person has a really weak core. Can you work on it? And I think being able to come at it different direction would be useful with some clients. I teach a lot of age 50 plus women, so menopausal pelvic floor issues beginning to kick in. So again, I thought this might be useful for that.
Excellent. Yeah, there are actually more studies done on hypopressive for low back pain than there are for pelvic floors.
Okay.
So there's just much
Sounds good.
Yeah. So I hope you're in the right place. So I hope you enjoy it as well. And then we've got Caroline Brown. Hi, Caroline.
Hi, good morning. Good morning, everyone. I'm up in a little market town called Olney, which is in Buckinghamshire, just north of Milton Keynes. I've been teaching for nearly 4 years. And I also do Indian head massage and ear candling as well. So this was anything about the body, and especially since becoming a teacher, really fascinates me. And I'm getting more and more fascinated about what we hold in the body and sort of like the feedback that it gives you. And sometimes we're not even really aware of it until you learn stuff like this. So yeah, I don't know anything about it, but I'm really interested to learn and expand sort of like knowledge in teaching and hopefully be able to pass it on, you know, and help others.
Excellent. Me too. I'm there, no pressure. So I hope you're all going to enjoy the course, because I'm like, yeah, it's very, very practical as well. So we're not going to do too much sitting about after this. So a wee bit, but not much. Nice to meet you, Caroline. Vanessa.
Sorry, hello, I'm Vanessa. I live on the Norfolk-Suffolk border, so quite rurally, but I teach in Norwich as well. I've been teaching for about 12 years. Completely naive to hypopressives, didn't know what it was at all, and I think someone else said until we sort of got the email from Body Control looking at it, and I think I'm definitely interested in when we've been talking about the pelvic floor, as Sue said, I don't really cue that actively in my teaching anymore. So I'm interested in different techniques that are going to naturally look at that and help with any issues. I'm interested in the fascia aspect, you know, in terms of, you know, where you can release that tension holistically. And when you're talking about, you know, where it can go with the TRE and that kind of releasing tension from tissues, I think I'm really interested to learn about. So I'm always looking for new techniques that kind of, you know, can use the breath and holistically hopefully try and address lots of issues. I'm also a massive stress merchant as well. I think to do with the 2 kids, which are 10 and 7, and one's disabled. So there's kind of lots to kind of put in place with her, and I just don't look after my own body enough. So I'm interested to see how this can help with my own body going forwards, and then seeing how it can help other people.
Excellent. Hypopressives are total mindfulness exercises as well, so they're really good for just keeping you in the space that you're in the moment, you know, which is again a really nice way to just combat stress as well.
Brilliant.
So it'll be really good for you too.
Exciting stuff. Thank you.
Thank you. And Donna, you're at last on my list.
Morning, everyone. I live in Bromham. I work alongside Caroline in Olney.
I looked at the course and thought it sounded really interesting, really hard to get on as well. So I tried to book on, and then Lee was like, oh no, we need to put some more courses on. We ran out of dates, there's no spaces. So that's always a good sign. So yeah, I was really pleased I got on the course, and pretty much like what everyone else has said, same interest, learning new things, bringing it into class, helping others. And I think the way everything's going at the moment, there's a lot of stress, a lot of mental health. That's a big thing. I have clients that come to class that have lots going on outside. So yeah, anything that can make them feel better about themselves or release any tension is a bonus.
Excellent. Brilliant. Nice to have you here, Donna, too. And hopefully this will be the pathway to that. So, I mean, the amazing thing about Hypopressives is it can be so easily adapted into other modalities, which is what we're always looking at. So we're going to have a little bit of slides just now. We're going to come back and revisit them after lunch as well a little bit. Just so that we make sure we go through kind of a little bit of theory. So I'm going to share my screen, hopefully successfully. I'm also going to put me on Spotlight. And then I'm going to put you all on, right, I'm going to put you all on gallery for me, so I can see you all. And then I'm going to share the screen, and hopefully this will be a successful sharing. So sometimes it decides it's just not going to do it for me. Sometimes the internet does the same thing as well. So I am just going to put it on a slightly different screen. Okay, so please ask questions as we go if you want to. So this is an intensive course. So usually my level 1 course takes 15 hours. So we are doing this in 5. So it is an intensive course. So we're going to get through as much material as we can. And I am always here for you to ask questions afterwards if you need to as well. So just remembering that, you know, this is not just a one-stop shop. We're not done here. If you need to ask questions about anything we've done, then I am always available. So Hypopressives are a holistic way for us to address the pelvic floor issues. We combine posture, breath work, fascia mobilization, neuroeducation. We also do tensioning. It's more like active stretch than tensioning. Tensioning is quite a hard word. I prefer the word active stretch, and muscle train activation. I also use a lot of visualization to encourage the pelvic floor to mobilize in a functional way. So we're going to do all this today. We're going to go through exactly what my clients go through to start with all of you. The aim is to almost forget about the pelvic floor and focus on everybody else in the team, and then weave the pelvic floor back in again through visualization. Now, we are going to learn apneas in a bit. And on the internet, if you look on the internet about hypopressives, you will usually see, the ones you'll see which are most visually captivating are the one in the center here and the one to the center right. This is not a drawing in technique, and we're going to talk about that in a minute. These people, all of these people have a really beautiful, effective apnea breath. So everybody is different, and that's a really important takeaway from today as well, is that a lot of my clients, when they learn hypopressives, they are expecting their body to look like the one center right or center. And that is, these look like this because of the size of their rib cage, the amount of body fat they have on their bodies, but predominantly is about skeletal size. And so I try to get people to be really mindful of not getting hung up by what things look like, but more about how things feel in their bodies. And this is here for you to look back at and use with your clients just to show them the differences as well. And, you know, if they're saying, oh, I'm not managing to get this. Mine looks a lot more like maybe top center right, top center, which is why I don't flash mine all over the internet, because it's not quite so dramatic as everybody else's. But I have had amazing results regardless, because it's about what goes on inside rather than what you can see from the outside. Okay, so benefits of hypopressives. These are some of the benefits. There are loads of benefits though, and yeah. So enhances posture, alleviates back discomfort and strengthens the core, promotes a balanced resting tone. So what we're looking for is a resting tone across the whole body. We're looking at the difference between strength and resting tone. I want my ladies to have an amazing, gentlemen to have an amazing resting tone in their body. If they want to build strength, then they can stay with me and do strength training as well. However, for the point of view of pelvic floor, I want resting tone. It enhances lung capacity through the hypoxic breathing that we're going to be doing. We do a tiny bit of, and I'm going to talk about that in more detail, don't worry. We boost athletic endurance, so you can actually go for longer because you have better lung capacity, better recovery times, and better stamina. Enhances intimacy and sexual satisfaction. Women start to feel much more confident about their bodies. Men feel much more comfortable about their erections, which perhaps they haven't had until they start doing hypopressives. And the women that have, most women that are willing to tell me, will say, I've had so many women after workshops go, I had the most explosive sex last night. And that's what they come back with. And this is to do with the fact that we're getting more oxygen to the capillaries and out into the extremities and into the pelvic floor as well. It's about oxygen transference, and it is also about activating the fascia and the connective tissues, which is connective tissues. We promote a functional pelvic floor, so I'm not looking for a pelvic floor, I'm not necessarily looking for a pelvic floor that suddenly becomes a 5 on the Oxford scale. So when they look at pelvic floor strength at physiotherapy, they look at the Oxford scale, which goes from 0 to 5, 5 being when they can grip really hard. The issue is with that is that women who have a hypertonic pelvic floor will be at a 5. You know, it doesn't mean that they have a functional pelvic floor. It just means they've got a tight pelvic floor. So the Oxford scale doesn't always work with every pelvic floor. It also reduces anxiety and stress and improves lymphatic drainage. We're improving lymphatic drainage because we're activating the rib cage, and we're also starting to activate the fascia within the intra-abdominal area. If we bypass the rib cage for breathing, which a lot of people do, you're not going to get that same lymphatic drainage. So the history. So it's good to have a little bit of history here. So when we first see hypopressives in the apnea, so when you saw those pictures back here, you might have thought, oh, I've seen them in yoga. That's like an Uddiyana Bandha, which is a lock. So when we first see them, we might feel that it's a bit like Uddiyana Bandha or the Nauli from yoga. Oftentimes when people come to hypopressives, this is what they're using. You know, if they've looked at the internet, they've gone, oh, all right, okay, so what I'm going to do is I'm going to pull my tummy inwards and upwards, and that's going to make me look like that person on YouTube or, you know, Instagram or wherever. However, Uddiyana Bandha is a lock, so it's created to tighten and control the thoracic area of the body, and it's taught as a drawing inwards and upwards maneuver. The abdominals is after a forced exhalation. So we're going to be talking about how different this is. Uddiyana Bandha from yoga is a forced exhalation. It's only in certain positions, so there's always a leaning forward happening, and it's creating a lock. So it's not creating a through active stretch. And we're going to talk about that in more detail when we practice. I'm not going to teach you Uddiyana Bandha because I'm not a yoga teacher. However, if you wanted to go and learn the difference, you can as well. I think we might have a picture as well. We're going to learn how different it is. So, Uddiyana Bandha. This is what it looks like. So I thought it'd be a good idea for you to see what it looks like. So we're going to have a little look at this video. And hopefully it'll play. So what he's doing is he's drawing inwards and upwards. So he's creating a lock. He's not really activating his ribcage that much. It's activating a little bit because of the activation of the abdominals, but the primary mover in that is the abdominals, so the deep transverse muscle. and it's a pulling inwards and upwards. However, we do have some of the same benefits that they have from Uddiyana Bandha. So what we do also strengthens the abdominal muscles and diaphragm. What we do also massages the abdominal viscera, the solar plexus, the heart and the lungs. And we're going to talk about how it does that in a lot more detail too. They say Uddiyana Bandha increases gastric fire, improves digestion, assimilation and elimination, and purifies the digestive tract of toxins, which also hypopressives do, without having to lock. It stimulates blood circulation in the abdomen and blood flow to the brain. And we also achieve this through the wee bit of hypoxic training that we do. So hypoxic training, there are lots of studies on it these days about how that hypoxic, the moment of breath hold and then intermittent breath holding, how that crosses the blood-brain barrier and so increases oxygenation to the brain. And there's lots of research starting to be done on using it for things like Parkinson's and Huntington's disease. So this is the breath work is having a move forwards into kind of primary health care for illnesses like that. So it also stimulates and lifts the energy of the lower belly and to unite it with the energy in the navel and the heart. And we're also, if you think about what we're doing once you do it, a lot of people say that they feel like they've found an energy line through their body, or they found a through flow through their body. And my yoga teachers always say that it connects their chakras. So when they come to do the courses with me. So this one, I think, oh no, we've done that one. That's good. We've done the abdominal lock. Let's move on. Let's move on. Yeah. So the other places you might have seen it is, and this is more the true vacuum that we're going to be doing. So the first person to really do a vacuum in the same way we're doing, activating the serratus and activating the rib cage after an exhale, were the bodybuilders. So Arnold Schwarzenegger and Bruce Lee are both here doing an apnea. And they're doing it so they can show off the musculature of their body. So they're actually creating a vacuum. And this is the one that we're going to be doing. Yeah. So, and they've used it not just to show off, but also to tone and strengthen the deep transverse and the obliques. So it's quite interesting that, yeah, Arnie was one of the first to actually do an apnea. Okay. So a little bit more about the history of pelvic floor stuff. Dr. Kegel, it was pretty phenomenal for a man back in 1948. He did an 18-year study of the pelvic floor. He really did want to do something amazing for women. You know, he really wanted to solve this problem of urinary incontinence and also of pelvic organ prolapse. So he said that women could exercise the pelvic floor by doing squeezies of differing intensity, which is what we do nowadays as traditional pelvic floor exercises. But he didn't think that telling women how to do them would work. So he invented his Kegel pyrometer, which we're going to have a little look at because it looks very similar to a Kegelizer, which are the things that women get these days, except instead of having a little a dial system for seeing if there's tensioning or not, a bit like a blood pressure monitor. Now we've got apps on our phones. So what did he do? He didn't solve entirely the issue. The issue with Kegels is this: they are often embarked upon with very little or no clear instructions. Women will think, oh, I've got pelvic floor issues, I'm leaking, I feel a heaviness, I'm going to start doing Kegels. So they'll Google it, they'll Google pelvic floor exercises, and they'll start to do them at home. Now, the issue is that people will start to recruit different muscles apart from their pelvic floor muscles. They'll use their abdominal muscles, they'll use their hip abductor muscles, they'll use their glutes instead of using their pelvic floor. The other issue with pelvic floor exercises, I'm just going to see if I put it over here now. So the other issue with pelvic floor exercises is that women will perhaps have had prolapse issues for a while and they'll have been holding. They'll have got themselves in a holding pattern or a tensioning pattern. And so when you're holding something tight and then you tighten it, so it's like doing a biceps curl, except with these are fast twitch muscles rather than a slow twitch for our pelvic floor. So if you're doing a biceps curl and you start here and you're tight already, and then you come to tight, and then you come back to tight, and then you come to tight, you come back to tight, you're never fully releasing. So eventually the muscle's going to get so tired that it's going to give up. Now, women who come to Kegels, who are already in a hypertonic position, will start doing Kegels, and initially they'll have good results because they are still tightening. But eventually, so when people go back and look at studies of women, if they go back 2 years later, 3 years later, the Kegels are no longer having any effect. In fact, women's symptoms are worse. So, and the reason for this is that they're hypertonic. The majority of women who have prolapse issues are hypertonic because they are in a holding pattern. So unless they're taught to release before they start doing traditional pelvic floor exercises, they are going to end up doing themselves more damage than good. And we don't have enough pelvic floor physios across the UK who will investigate women and make sure that they're doing them right. If you have a baby in France, then afterwards, and Belgium, then afterwards you see a pelvic floor physio, and the pelvic floor physio teaches you how to relax and how to contract your pelvic floor. But we don't have that in the UK, and in fact, most of the world doesn't. So that's the downside to Kegels. Back in Victorian times with Queen Victoria and with Queen Victoria had a prolapse, and what they used to do with her is the physician would come in the morning and they would hold her up by her feet and hang her upside down to make the prolapse go back in. And this was a traditional method also used, we think, in Egypt, because there's lots of pictures of women hanging from doors. So it seems to have been a traditional way for them to deal with something's coming out, so we're going to hang her the other way and hope it stays up that way. So the issue with that is that, yes, initially that would help, but you're not, so it'll be up for a bit, but the minute you stand up or the minute you cough, the minute you sneeze, everything is going to, come back down again, because it's not being held up by resting tone, it's not being held up by functional ligaments, it's just being held up by gravity. So Marcel Caffrey's, he is the granddaddy of hypopressives. In the 1980s, Marcel Caffrey's discovered hypopressives. He was doing an internal investigation of a woman's prolapse, and his hands were really cold, and when he went to touch her, her prolapse disappeared back up inside. And he was like, oh my goodness, what's this? And then so he went on a journey and investigated what had happened with her body and discovered that certain breathing techniques done on an exhalation will have an effect on the pelvic floor. He also discovered that an antagonistic postural relationship between the serratus anterior and the thoracic diaphragm, so that when tensioning the serratus, a thoracic expansion was provoked, while a tonic relaxation of the thoracic diaphragm caused a decrease in intra-abdominal pressure. Don't worry if that doesn't make any sense. It's going to make loads of sense when we start to do it practically. So this was the beginning of hypopressive techniques, and he called it, to start with, diaphragmatic aspiration techniques. And Marcel is still coaching in Belgium, and he has schools all around the world teaching hypopressives as well. He will not teach anybody who is not a physiotherapist, though. So he will only teach his method to physiotherapists. The next one that's comes into the way hypopressives teach now is Françoise Mazur. And this was, again, about looking at neuromuscular techniques and posture. So Françoise used posture and stretch, thinking about muscle chains in the body. So back in 1947, we didn't really know that much about fascia. So it was more from a musculoskeletal point of view that pelvic floor was addressed. And Françoise did it through creating engagement through muscle chains, and it's this engagement through muscle chains that we've also adapted into hypopressives. And Marcel adapted, and later on, low pressure fitness, my trainers Tamara and Pitti, and now us too at the IHC are adding more and more to our repertoire as we go through looking at muscle chain activation. So this is all here for you to have a little bit of a deeper look at as well when you read through. And then we've got Philippe Souchard, who also came along and is a physiotherapist. The manual therapy approach that they used was to revolutionize the understanding and treatment of musculoskeletal disorders. They saw that injuries, repetitive movements inherent in daily tasks, as well as demands from work and sports activities that necessitated prolonged postures, contributed to a shortening of muscle fibers. And we have that a lot in daily life now. I mean, you just have to look at kids, and we're going to talk about this more in the fascia side of this course. But kids, because of their head positions with phones and things, their tendons that are called goggly tendons are starting to adapt and think that that is the correct posture pattern, so that feels really comfortable. So that they're almost retraining their bodies to be in these really poor posture patterns that are going to have a massive impact on their pelvic floor. From the point of view of women, if you've had multiple babies and been up, or even one baby, and been up all night either bottle feeding or breastfeeding, your posture pattern almost becomes normalized into this kind of curling shape. And this has a huge impact for your pelvic floor. That forward head position puts enormous pressure on your pelvic floor. So looking at those, Philippe decided that there had to be something done about it. So the Philippe Souchard's method looks at altering the posture and ensuring consequences. So he looked at how those posture patterns created pain, inflammation, and joint compression. So the GPR aims to address these issues by offering a unique and dynamic approach to musculoskeletal rehabilitation. And we're going to look at this much more when we come into the movement side of hypopressives. But in the side we're looking at today, the active stretching, that's what we're looking at readdressing. So we're looking at getting people back in a great posture pattern, and we're looking at thinking about active stretching through their fascia rather than just their muscle chains. Okay. So you'll see there are posture patterns that Philippe looked at that we're also going to be looking at in hypopressives, about alignment, essentially. And we're also going to be looking at Francoise's idea that we need to make sure that the rib cage stays an equal distance away from the pelvis. A lot of postural imbalances come from the orientation between the pelvic floor and the rib cage, and we've become much more heightened aware of that within hypopressives. So next, after all of that became, Pitti came along, and he found hypopressives through Marcel Caffris, and he realized he'd already been on a whole journey about pelvic floor health and about core strength. So it was very much of we shouldn't be doing sit-ups, and he's a physical therapy expert. So we shouldn't be doing sit-ups because they create too much intra-abdominal pressure. He was looking originally at planks, then he found hypopressives, and then he started bringing it out so it wasn't just for physiotherapists. Then he met Tamara. Tamara did her thesis on it, and Tamara has a doctorate in sports medicine, and she evolved hypopressives initially into a much more movement-based practice. Marcel's is very, very static. Pitti and Tamara together brought lots of motion into it, brought more of the fascia connection into it. So they're much more dynamic, and these are my trainers. So this is who I learned from in Spain. Then the International Hypopressive Council was formed out of all the international trainers from Low Pressure Fitness, because there was a very Spanish infighting happened. It was mental. They fired Tamara, fired Pitti. It was all a big mess, and then and it just we didn't know where we were. It was very, very Spanish, very kind of flamboyant. And so we as international trainers decided that we were going to get together and we were going to create a school that would have a gold standard of training. And we've also brought all our expertise into it. So all the trainers that around the world have different expertise, and we're slowly evolving hypopressives to become more than what it was. And we really want it to be something that is has a multidisciplinary approach. So it can be used within yoga, used within Pilates, used within postural training. So it doesn't have to stand alone. It can be adapted to within your modality, and that's what we're looking for. Okay, so we're going to look at different breathing patterns. So we're just going to have an overview now, and then we are going to, do you know what, maybe we'll do it, and then we'll have an overview. Yeah, I think we're going to do some, because we've been sitting for ages, so let's do something practical. So I'm going to come off this slide, and we're going to come back to this in a bit, but let's go through the different breathing patterns and try them out in our own bodies, and then we can come back and have a look at this and it'll make more sense. So I'm going to stop the share here. And I am going to change my camera, hopefully. Yay, look, it worked. That's amazing. So what we're going to do is we're going to come to let's come to a lying down position, or sitting up. Let's sit up. Let's sit. I'm trying to decide which way to do it today. Okay, so let's come to a sitting position. Let's just go through the different breath techniques that we can have. You could do standing, sitting, or lying down. It's entirely up to you. So we just get a little bit more movement into our bodies. So you can choose where you want to be. So the first breathing type is apical breathing, which is when we breathe into our upper chest only. So we are going to just feel what that feels like in your body. So you're going to take some breaths and just breathe into the upper body. So inhaling and really breathing into here. Using your shoulders, your clavicle. Inhale. So the majority of people that come to me either breathe here, apically, upper chest breathing. So they either breathe into their upper chest here, or they're belly breathers. So this is the next one we're going to try. So this upper chest breathing, though, what happens with this upper chest breathing is that people really overdevelop their secondary breathing muscles. So they overdevelop their scalenes, and they get stiffness and tightness in their shoulders, their neck, they get headaches, and it's all to do with this really stressful, shallow breathing. Yes, you do have lungs up here, so the top 25% of your lungs are up here, but the rest of our lungs are very much round the back of our body, caged within the depths of our rib cage. We do have an upper rib here, so our upper rib comes from the back of our neck here, underneath our clavicle, into our sternum at the front. And so we do need to breathe up here, but if we breathe solely up here, we create immense tension in our shoulders and our necks. And honestly, people have the most beautiful scalenes when they do this because they've worked really hard to develop those muscles. So I always comment on how amazing their scalenes look. The next breathing type that I see all the time is belly breathing. So people are taught to belly breathe as a way of relaxation, and they're taught that as being a diaphragmatic breath. Now, the issue with belly breathing is that people are not cued to use their rib cage at all. So belly breathing, we're going to have a little shot of. So you're not going to do, all you're going to do is you're going to breathe in through your lungs and out through your belly. So you can have your hands on your belly if you want, or you can just feel what that feels like. So taking some breaths in. And people are taught this for relaxation. Now, the issue with belly breathing is this. If we inhale and start to take in air through our lungs, and we don't recruit our rib cage, and we just breathe straight down, pushing into our diaphragm, then we push loads of pressure. So we increase the intra-abdominal pressure by a huge amount. So the intra-abdominal pressure is the pressure between our diaphragm and our pelvic floor. Now, if we're pushing out to the front into our bellies, we're also going to increase the pressure through what can be a really weak area for postnatal women or women as we age, so into the linea alba. So women that have a diastasis, if they're taught to belly breathe, then what they're doing is they're constantly pressing against that weak, stretched area of tissue, and this can increase their diastasis, not decrease it. The other issue with belly breathing is because we're creating all this intra-abdominal pressure. If you have a weak pelvic floor or weak back muscles, the pressure is going to find its way out through those weak areas. So we're essentially taking, if we think about a tube of toothpaste, we're essentially taking a tube of toothpaste and we're just squeezing the top of it and pushing all the stuff down straight into this area of our body. And postnatally, and as we age into perimenopause and menopause, this area of the body may be weaker, okay, and have weaknesses, and the pressure will find its way out. If we're only breathing up here, then we're containing the pressure very much up here into this tiny space, and that's why we create all these issues with shoulders and necks. The other breathing we see is paradoxical breathing. So paradoxical breathing is when we breathe backwards. So as you inhale, what I'd like you to do is as you inhale, I'd like you to pull your tummy in as you inhale. And as you exhale, I'd like you not to push it out, but just let it go a little. So you're never gonna, so inhaling, pulling your tummy in. Exhale, let it go a little. Inhale, pull it in. Exhale, let it go a little. So we're doing the breath work backwards. This is the hardest one to break. If somebody comes to you with paradoxical breathing pattern, it's one of the hardest ones to retrain people from. Usually it comes from a woman whose mother has constantly told her to pull her tummy in, pull your tummy in, pull your tummy in. If I meet my paradoxical breathers, a lot of the time if I ask them, did your mum always used to say, pull your tummy in? She's like, yeah. And so they've been trained to hold their stomach in for their entire lives. So it's not something that's come because of teenage years hiding their body away, or pregnancy, being unable to breathe unless they're flaring. It's actually come from something that's deeply ingrained, so it's much, much harder to break. The other breathing pattern we get is the flare. So this is when, and we're going to try this one. So this one, as we inhale, we press our ribcage forwards, and as we exhale, we bring it back. Then it's very much a postnatal, post-pregnancy one, but people can hold on to it for life. So they inhale and press the ribcage forwards. Belly expands, exhale, it comes back. So you can see this in people's breathing pattern because as they inhale, they'll arch their back, and as they exhale, their sternum will sink. And so this is a kind of flared breathing pattern. So none of these are optimal. So we're going to have a look at an optimal breathing pattern now. When we inhale, we are increasing the pressure. We're not increasing the lungs are different. So we're not talking about lungs, we're talking about intra-abdominal pressure. So we're increasing the pressure in this whole area here. What we want to be able to do is we can't change the pressure, but we can use the pressure differently. We can increase the space and volume of the body to dissipate the pressure around a larger area. So we can have a uniform distribution of pressure. So as we inhale, what we're going to do is we're going to place our hands around our ribcage for a moment. And we're going to use our ribs to help widen the thoracic area. And this is going to help create more space for the pressure to be deposited uniformly. So we're going to take a nice deep breath in, and as you do, I'd like you to open your ribcage towards the sides laterally. So your abdominals will engage, everything will start to engage, and then as you exhale, just allow the ribcage to close. So now what we're doing, instead of getting that tube of toothpaste and just squeezing from the top, now we're pulling out all the sides and things and creating space for all the toothpaste to be in a uniform space around the tube. Okay, does that make sense to everybody? Perfect. Okay, there's something else I need to talk about with belly breathing. So I'm coming back to belly breathing for a moment because I want to talk about what's going on with the muscles and the body. So as we inhale and bypass the rib cage and just breathe out into the belly, the focus is on the belly and pushing the belly forward. Can any of you tell me which muscles in the body are designed to push out towards the front? It's a bit of a trick question. Yeah, there isn't a single muscle in the abdominal wall that's designed to push straight out towards the front. The deep transverse muscle, which is our deep transverse muscle, that attaches to the thoracolumbar fascia at the back, it attaches to the top of the pelvis and the bottom of the rib cage. It comes all the way around like a corset, literally like a corset, till it hits the front here. And it's, instead of the striation marks of the muscle being up and down, so connecting from the rib cage to the pelvis like this, the striation marks on the diaphragm actually come round like a corset, so they wrap round. So the short fibres, the fibres are connected, the long fibres are connected along the pleura, the connection to the rib cage and to the top of the pelvis. So it is like a corset. The obliques are designed to move. So as we inhale, the deep transverse muscle, if we open our rib cage, the deep transverse muscle opens to the front, to the sides and behind. If we just belly breathe, the deep transverse muscle is just being pushed out towards the front, and we'll create a contraction in the back of our muscles, a contraction in the sides of our muscles primarily, and we'll just be expanding to the front. So we're not getting that co-activation of the transverse. We want the transverse to be working with the thoracolumbar fascia and with all the other muscles in a uniform way. Now, the other muscles are the obliques. So the obliques, the external obliques attached to the rib cage, and they slide all the way down to the pubic symphysis. And they're designed also to work with the rib cage. So as we widen the rib cage, they engage by drawing, by stretching, and as we exhale, the obliques contract. So they're moving up and down, not out towards the front. Then the rectus abdominis, which is the one on top, has lots of different, it's for rotation and lots of different things going on. But it also has this function of creating an active tensioning or an active stretch from the pubic symphysis to the solar plexus. So its job is to help hold that front line in that active stretch that we need to have a great posture and great engagement between our pelvic floor and our thoracic diaphragm. So there's not a single muscle that's designed to push out towards the front. So I'm asked a lot about belly breathing and how, we're told belly breathing. So if you look back at the Sanskrit for belly breathing, or you look back at the actual instructions for belly breathing, and you can do this in your own bodies, the belly breathing is you take 3 fingers and put them above your belly button. And then you imagine 3 fingers inside your body. Okay, so think about where that is. You've got your fingers, 3 fingers above your belly button, and then think 3 fingers inside your body. Now, I'd like you to take a nice breath in, and I'd like you to open your ribcage to the sides and behind, nice and wide, and I'd like you to think about what happens to your diaphragm. So where do you think your diaphragm is hitting when you widen your ribcage to the sides, like that? Yeah, so your diaphragm is coming down and it's massaging the top of your abdominals, about 3 fingers up from your belly button and 3 fingers in. So when we widen our ribcage all the way around, we are belly breathing. Our diaphragm is coming down into that point in our belly that belly breathing talks about. So belly breathing is not about pushing the belly out. Belly breathing is about breathing into the abdominals, into the intestines, into the top of the duodenum, and massaging it. And at the same time, as we open our rib cage and our diaphragm, what happens in our diaphragm? So a little bit of anatomy. As we widen our rib cage to the sides and behind, which we're going to do much more of in a moment, what happens with the diaphragm is the central tendon of the diaphragm pulls down and contracts, and the muscles spread out. So it does a drawing down and a widening. And this drawing down massages the top of the duodenum and the top of the stomach, but it also pulls down the heart and massages the heart. So the heart then, and then as we exhale, the diaphragm then draws back up underneath the rib cage and draws the heart back up with it. So we have this beautiful connection between the abdominals being massaged and the heart being moved and massaged. It's on a small scale, I'm doing these big movements. It's not like we're pulling the heart up and down, but it's to give you an idea that these things work in synergy with each other, but only if we're widening the rib cage. If we're just pushing straight down, we're not getting that same contraction. We're not allowing the central tendon of the diaphragm to do that contraction. We're just pushing pressure down the way. So it's an important thing to differentiate between. The other thing that the diaphragm is doing as we pull down like that is it's massaging the top of the adrenal glands, which becomes increasingly important for women as we move through perimenopause into menopause. Because there is supposed to be a beautiful change between your ovaries producing all the hormones. It's supposed to beautifully slide over to the adrenals doing the job for you. And in some cultures where women are given a lot of support and are not so stressed as in our culture, there are fewer menopause symptoms because there's much more of this connection with the body. I believe, and yeah, in my research into this because this is where I'm heading at the moment. But if we're in a really high stressed, we've got kids, we've got a job, we've got a husband, we've got parents to look after, we've got all of these other things going on, our breathing becomes really shallow. So a lot of my women, the majority of them breathe up here. So they've never got this connection with the adrenal glands. They've never got this connection with the pelvic floor. There's never this connection going on. Okay, any questions so far? Because we're going to go a bit into a little bit more about breathing. I'm going to do a really practical thing with you. Sally and Sue. Sue.
Hi, I've got a question. I forgot to say earlier, I trained a long time ago to be a physiotherapist. And I do remember when we were thinking about how much the ribs expanded and the lungs underneath. Is it true that the right side should expand a little bit more than the left because you've got the heart? Because I'm just breathing here and thinking I've got much more expansion on the right side than the left. Is that normal?
Yes, yes. So
Is it?
you've got because of where the heart is,
Yeah.
there's one side of your lungs has got more than the other side. So it's got an extra
Okay.
little, so you get more expansion. Sometimes though, Sue, when people breathe and use their rib cage, they actually find that their right side doesn't move as much as their left. And there's a big reason for this, because underneath the right side is the gallbladder and all these other associated. Sometimes the fascia has become so stuck in there that it's a phenomenal effort to get to move to start with. But we're going to talk about how to mobilize that.
Thank you.
Great
Thank you.
question. Right. Sally.
Hi, I was just in my experience of just teaching and trying to get people to breathe with their rib cage, I find that an awful lot of men cannot move them, and I don't know whether that's just my clients.
No, it's not just your clients. So women get into posture patterns because they spend their whole time looking down at small children, so they start to sink, and women's eyes go down all the time. Or they've been pregnant and they've flared so much, so they've got or they're prolapsing, so they've got different posture patterns we're going to look at when we come to standing, especially, like loads of different posture patterns that women recruit to help themselves out. Men are told shoulders back, stand up straight, so they end up with this barrel chest that's totally stuck forward, and they cannot move this rib cage at all. So that's one of the big ones with men, is this kind of barrel chest flare. And a lot of men will have diastasis because of this permanent position of their rib cage that's creating this kind of torsion in their bodies. And also beer bellies, they also do diastasis as well. Rods in, hold on a second, Vanessa, tell me about it. Hold on.
Yeah, I've got rods from scoliosis, that mostly in that thoracic. So I've got limited spinal movement there, but I think because of that, and probably there's scar tissue and fascia dysfunction all over the place, I tend to probably just bypass that area. So I'm probably I'm not even aware really of where I'm breathing. I think that's probably not good. It feels like I'm not breathing, but obviously I am somewhere. But it's probably here. And maybe when I'm then focusing on it, I put it into the belly, because I think I probably just bypass that area far too much because of that. Well,
there'll be lots of scar tissue there as well, Vanessa. So it's about mobilizing that scar tissue to start with as well, which we'll be doing when we start.
I think that's really going to help. Yeah.
Yeah.
Thank
Definitely.
you.
Any other questions about this so far? Okay. Is the anatomy okay for everybody? Yeah, with what the thoracic diaphragm does, because that's going to become more important. Okay. Sue.
Yeah, sorry, I've just remembered I've got quite a few ladies who sing, they're singers, and they always want to sort of work on breathing. When I sort of look at the way they breathe, it does seem to be very sort of belly breathing, like they've been taught to take it into the belly, but not into the ribs, like you've just been discussing.
Yeah, so if they're taught to just take it into the belly, then I mean, what I say to my singers who come to me, and I've got a soprano, she's just mental. She holds an apnea for far too long, but she's got phenomenal lungs. But what happens then is that you're not using and recruiting and giving space to all your lungs. So once they start to learn this thoracic mobility here, then their singing gets much, much better. They've got much longer for their notes. And it also stops them from over-recruiting scalenes and things like that when they're singing, which can create immense neck tension in singers as well. We have a real connection between the epiglottis, the diaphragm, the thoracic diaphragm and the pelvic floor, but just the whole mouth area, all the way down to the pelvic floor, which we'll be talking about in much more detail too. So it's really important that we see the connection between the three. And yeah, so what I say to them, Susan, I'm like that, where are your lungs? And they go, and some people look at you and go, where are your lungs? And they look really confused, you know, because, you know, there's just no idea. And I'm like, well, your lungs are housed within your rib cage, you know, and predominantly towards the back of the rib cage and into the kind of center of your body. And at that point, the kind of light goes on that, you know, opening the rib cage is going to give them more space to breathe, and that really helps. Yeah. Okay, so I thought what we'd do now is that we're going to go through the assessments I initially do with people. So I'm going to treat you all like you're my clients. So we're going to get all of us, so I start all my clients off in supine, because that way they can't cheat with their posture. So we're going to come to a supine position to start with. And then I'm going to talk you through different things. I'm going to ask you questions. And I don't want you to change anything when you lie on the floor, by the way. I don't want you to go into an immediate, I'm going to correct my posture and now I'm lying on the floor. I want you just to land on the floor and don't change anything at all. Just land there. Don't try to adapt anything, don't change anything. And I'm going to go through why I ask these questions. So we're going to have knees bent, feet flat on the floor. Excellent. Okay. Wait till everybody's down. Okay, so the first question I ask all my clients is this. When they arrive on the floor, the first question is, where are your rib cage? Where's your rib cage in relation to the floor? Is your rib cage off the floor or is your rib cage on the floor? So don't try and adjust it, just be aware of what's going on. Okay, so why am I asking this? I'm asking this because I want to discover whether they have a rib flare or whether they have an anterior tilt or posterior tilt of their pelvic floor, of their pelvis. So, and this becomes really important for thoracic and pelvic floor orientation. So the next thing I get them to do is teach them how to find a neutral pelvis. Now you all know how to find a neutral pelvis. So I'd like you now to find a neutral pelvis. Now I ask again, once they've got the neutral pelvis, I say, where is your rib cage in relation to the floor? Now, if their rib cage is now on the floor when it was off the floor before, that tells me that they have an anterior tilt in their pelvis. If their rib cage was on the floor and we've got a neutral pelvis now, that tells me, and now their rib cage is slightly off the floor, it's not completely all the way on the floor, that tells me that they had a posterior tilt. So I'm looking to see where, if we've got the neutral pelvis and their rib cage is still really far off the floor, that tells me they've got a rib flare. So I've got these different things that I'm finding out from these two questions that I asked them to start with. So I'm looking to see how disorganized their thoracic diaphragm and their pelvic floor are. Are they lined up with each other? Is their pelvis lined up with their rib cage? And so these are the questions I asked to start with to find out. And it also gives them a bit of an exploration through their bodies. So now, once we've found neutral pelvis, I ask them to see if they can reach their rib cage, the back of their rib cage towards the floor, keeping their lower back off the floor. So the bit directly underneath your belly button, your lower lordotic spine, I want just to have a little bit off the floor. Like you could put a blueberry under there and not squash it. And the next question I ask them is about their heads. So I'm like, so lying on the floor just now with your head on the floor the way it is, are you looking straight up towards your ceiling or are you looking above your head? So if they're looking above their head, that tells me that they've got a bit of a forward facing head position. So then I would get them a block or a cushion or something to put their head on initially while we work on getting their posture into a great place for them. Okay, so after this, the next thing I get them to do is breathe. So I'm going to get you all to forget kind of what I just said, which you probably could do. And what I'm going to get you to do is just breathe.
So you're just going to breathe the way you normally breathe. So what I'm looking for here are those posture patterns we just talked about. So I'm looking to see where people naturally go with their breath. So we're looking to see whether they naturally come to upper rib breathing, abdominal breathing. Occasionally I get people who recruit their ribs, but very, very occasionally. Good. And then once I've ascertained what's going on with their breathing, the next thing I'm going to ask them to do are a couple of tests. So these are assessments that we can go back and look at again later. So we do what's called a cough test. And the first thing I'm looking for is to see how well their abdominals are recruited when they cough. So we're really, a cough increases intra-abdominal pressure by masses. So it's one of the biggest tests we can do. So I'm going to get you to cough and be aware of what's going on with your belly. So you can put your hands on your bellies if you want, or you can just be aware. I want you to feel what happens when you cough. So just cough. Good. So we've got a scale in hypopressives, and I'm going to send you the assessment sheet that we use after this as well, so along with the video. So what we're assessing is this. If you cough and your abdominals come up, they stay up for ages and take ages to go back down, that is termed as a level 3 in hypopressives. And it shows me that your abdominals are not compliant. So when you cough, your body is not helping to absorb the pressure of the cough. The cough is just pushing out through the weakest area, which is your abdominals. If you cough and your belly goes up a little and then comes down quite quickly, then that's a 2. So that showed me that your body, your transverse abdominis is really trying to kick in and support you. So there is some activation, there's co-activation going on. If you cough and your belly button kind of stays where it is, that's a 1. So that showed me that you're pretty good. So especially people who've had babies and are later on in life, that's a great place to be. If you cough and your belly moves in, that's what kids do. So that's showing a really lovely compliant transverse abdominis muscle. So it's really showing that your body, as you increase the pressure, can manage to control it. Okay. So that's the first one. So then we check, and we can go back and recheck this with clients 6 weeks later, and there can be a massive difference. You especially get the 3, where it comes up and moves about, if they've got a really big diastasis. So if they've got a really big diastasis like I had, mine came up, stayed up for about half an hour, and then slowly went down again the first time I did this. And I was the worst I've ever seen. So, you know, most people are much better than mine was. So the next one we do is a vulva test. So I get my ladies to take their hand and place it on their vulva area. So you're going to put your hand on your vulva, and you're going to cough. And you're going to feel what happens when you cough. So again, it's a cough test. So again, this is measured in 3. If you cough and your pelvic floor comes all the way out into your hand, then it's a 3. And it's showing me that your pelvic floor muscles are not, they've not got great resting tone, and they're also not working with the pressure in your body. What's happening is as you increase the pressure, they're just going, oh, shit, that's not work for me. If it goes out, comes back in quite quickly, again a 2. If it stays where it is, it's a 1. And if it goes back up when you cough to kind of counteract the pressure, it is a 0. How did you all do? 1s, 2s, 0s. Let's do abdominals first. So where were you on abdominals? Was 3, 2, we can have fingers up. 3, 2s, 1s, 0s. Good. 3s, okay, yeah. That's how mine was. Okay, good. Okay, 2s, good. Okay. Okay, good. And for the cough test for the vulva area, where are we at? 0's good, good. Some great pelvic floors, excellent. Good, okay. So again, we can go back and retest this with people 6 weeks later after they've been practicing for a while, and there will be marked changes here. So the next thing we're going to do, any questions about that, by the way? Any questions about those tests before we go on? Okay, so the next thing we're going to do is we're going to start looking at the breath work. So lying back on the floor, we're going to make sure that our feet are flat on the floor, our pelvis is flat on the floor, well, neutral, and we're looking to have our rib cage nice and heavy on the floor as well. The back of your head on the floor, or the back of your head on a block, if you need one, so your eyes can gaze straight up towards the ceiling. Excellent. So then I get my clients and I'm going to ask you to put your hands around your rib cage with your fingers towards the front, towards the lower ribs, so the mobile ribs. So these are the ones that are going to get the most movement. So your fingers to the front and your thumbs towards the back, so you can feel the back of your rib cage a little too, because we want to activate the whole way around. So now I teach them the 360 breath that we're going to use when we breathe. And the first part of this 360 3D breath is the lateral to first dimension to second dimension. So we're going to inhale, and as we inhale, I'd like you to press the rib cage out towards the side, and we're going to inhale through our nose. And as you exhale, I'd like you to exhale through a relaxed jaw and just resist gently the closing of the rib cage. So take as long as you can of your exhale. So you're going to inhale through your nose, pressing your ribs towards the sides, and you're going to exhale just slowly through a relaxed jaw, slowly closing the rib cage back down, just allowing it to come back to its natural resting place. And we're exhaling. The exhale we're doing is we're exhaling to the end of our natural exhale. We're not trying to push all the air out. We're not trying to, increase pressure. Good. Now, the reason I ask people to initially exhale through their jaw and through a relaxed jaw is that a lot of people carry tension in their jaw. So if you're tense through your jaw and through your mouth, this reflects to your pelvic floor. If my clients grind their teeth or have tight TMJs, then that tells me that they're most likely got a hypertonic pelvic floor as well. So it's really important that we get them to start practicing relaxing the jaw. If you're able to keep your jaw relaxed, then I'm happy for you to also exhale through your nose. You need to be able to keep your jaw relaxed. So that's just a byword as we go through. So we're inhaling through our nose, widening to the sides, almost like wings opening, and then exhaling, resisting the exhale slightly as we close. Good. Now we're going to add the next dimension to the breath. So as we inhale, we're going to initiate the movement from the ribs opening to the sides, and then we're going to send the air back into the back of our body. So we're going to widen the back of our ribs as well. So we're going to inhale through our nose when you're ready, opening to the sides, opening to the behind. And as you exhale, you're going to slowly allow the rib cage to slowly settle back down, nice and slowly. Good. Really take your time with this, really feeling this mobilization. And what we're doing here is as we widen the rib cage like this at the bottom, we're stretching those muscles in the diaphragm, but we're also contracting the central tendon and pulling the diaphragm down. Good. Let's do one more here. The next part of the breathing, I only teach this part with my ladies who don't rib flare. So initially, my rib flarers are very good at lifting their sternum. So they don't need any more encouragement to lift their sternum at this point. I might come back and teach this as a selective teaching a little bit later on, but essentially for this part of the training is my ladies who are starting to sink. So they're starting to do grip with their rib cage, their upper abs, or they've curled themselves in, so their sternum is no longer active. So what we're going to do now is as we inhale, we're going to initiate the movement into our lower ribs, widening to the sides, then into our back, and then I'd like you to think about your sternum moving up towards the underside of your chin. So it's not pressing forwards off the floor, it's moving to the underside of your chin. And then as you exhale, I'd like you to keep the sternum slightly elevated as you allow the rest of your ribcage to close down. So we're inhaling through our nose, widening the sides of our ribcage, the back of the ribcage, and thinking about the sternum moving up towards the underside of our chin. And then as we exhale, we're going to keep that sternum slightly elevated as we close our ribcage down. And we're only allowing our ribcage to come back to its natural resting place. We're not shoving it closed or really closing it hard. Okay, how's that breathing feeling for everyone?
I find it really hard.
Yeah. Yeah, to start with, sometimes, Caroline, it is because it's like something you've never done before. And the majority of my women have never, ever, ever opened their ribcage before to breathe. And well, they have. They did up until the point when they stopped, because when we start as toddlers breathing like this with our ribcage, then we, but we lose it with life, you know.
So I can feel that my rib, so I'm getting that concave happening underneath my ribs, and there's there's more tone happening.
Yeah. So we're getting much, so Alison, you're right. So what we're starting to do is we're starting to activate the deep transverse and activate the obliques just with the breath work alone. So we've already got that engagement happening. Now, if we think about what's happening with our pelvic floor when we're doing this breath work, so you can keep breathing if you want, I'll just explain as well. So as we inhale and widen our ribcage towards the sides, we have some cool muscle things that happen. So as we widen our ribcage towards the sides, the diaphragm descends and stretches out. The psoas muscle that attaches to the back of your diaphragm and then comes down your back as a back muscle, then enters your pelvic floor and it merges with the iliacus muscle to become the ellipsis psoas, so it becomes a pelvic floor muscle. Then it comes through your pelvic floor and attaches to your femur at the front and becomes a hip flexor. As we inhale, widen our ribcage towards the side, and that tendon, the central tendon, draws down, we have a reciprocal release of the psoas. Then as we exhale and close the ribcage, the diaphragm draws up and it pulls the psoas back up with us. So every time you breathe and widen your ribcage towards the sides, you're getting this engagement of the psoas, releasing and then drawing back up. As we inhale and widen our ribcage towards the side, we also have a cool connection that goes from our sit bones. It's a fascial connection that goes from our sit bones through our levator ani muscle to our bladder and to the detrusor muscle around our bladder. Then from our bladder, it becomes what used to be called, when you're in utero, the urachus. So urachus is a tube that you excrete urine into your mum until you're 12 weeks in utero. After birth, after that, it becomes called this medium ligament. The medium ligament then attaches to the front line of the fascia chain that goes up through to the round ligament of the liver and becomes a falciform ligament. This ligament then goes on through the diaphragm towards the heart. So every time we inhale and widen our ribcage, this anterior chain releases all the way down to your sit bones. So like a loop going round. And as we exhale and close our ribcage, it draws back up. So we're getting this amazing synergistic movement. As we widen our ribcage, the back part, the posterior chain and the anterior chain are moving down and then moving up. So we've got this really, really cool movement pattern happening. At the same time as widening our ribcage towards the sides as well, we also have an activation within our spine and within our pelvic floor. So as we widen our ribcage towards the sides, our sit bones widen a little. It's not a massive movement, and you do really start to sense it eventually. The sit bones widen, the pubic symphysis softens, and the coccyx draws out from underneath, almost like a hook drawing out. Then as we exhale and close the rib cage, the coccyx curls underneath, the psoas draws up from the top, but it also draws round from the bottom. So you've got this beautiful tensioning of that active stretching that posterior chain. So the whole pelvic floor expands on the inhale. And as we exhale, we're wanting the pelvic floor to come back to a nice natural resting position. In the same way, we want the ribs to come back to a nice natural resting position, and we want the diaphragm to come back to its nice natural resting position. So we're looking for a resting position on the exhale, not a tension position. Okay, does that anatomy all make sense to everybody? Vicky, speak. Sometimes I get lost in the anatomy, so do speak. Did you put your hand up, or is it just it's the TV? Eh? Okay, any questions? Okay, obviously I don't tell my clients all this anatomy. I'm telling you guys all this anatomy so you understand what this is. With my clients, I just teach them the three-dimensional breath at this point. And if they ask, I tell them about the cool psoas muscle, because the psoas muscle is one of the best muscles in our body in lots of ways. because it's got these three hats. It's our emotion muscle in the center of our body. So it's the muscle that curls us up when we need to curl up. It's the one that puts us in high alert when we need to be in high alert. And so it is really at the center of our being. And it is so interconnected between the diaphragm, the back, the pelvic floor, and the legs. So it's huge. Any questions? Anne-Marie, hit me.
Whether it's surgical scars or just fascial adhesions, if somebody's noticing that I'm noticing on the right side of my body very much less movement, and I do have a lot of surgical scars, would you stay focused on that side and just relax and try and invite movement in there, or would you just let the body do its own thing and just continue to focus bilaterally? What's your thoughts on that?
So I continue to focus bilaterally, because otherwise what happens if we favor that side, then we start to have an imbalance on the other side. And the great thing about hypopressives is if we focus bilaterally on it, we're getting that uniform engagement in the pelvic floor as well. So we're not creating tension on one side. If we think about the pelvic floor like a triangle almost, if we start to focus on one side of, say, the rib cage or the body, then that one side of that pelvic floor is going to be activated differently than the other. And when we come to do more movement in the second part, we do looking at asymmetric movement rather than symmetrical movement. But when I first start people off, we really want the pelvic floor to start working symmetrically. And although I never really talk about the pelvic floor is always in the key part of my teaching. I never talk about it with my clients, but all the work that we do is all about getting that unilateral activation or bilateral activation of the pelvic floor.
Thank you.
Great question. Any other questions about that? How is it feeling in your bodies?
I feel a lot more open in my shoulders. I'm a real shoulder holder, and I feel they've dropped.
Yeah, you've got great scalenes.
Yeah,
great scalenes.
Yes.
So you start totally noticing people's bodies and where they hold
I
their
do.
tension,
Yeah, I'm always busy, hurrying.
Yeah.
They're getting me. I sometimes lie with a softball or Franklin ball under my front, on my front, and do each side of the rib cage, and that brings my shoulders back into place.
Yeah, that the Franklin method for that, and the lying, and there's also block therapy as well as another one where you to release the fascia that way. It can be immensely powerful as well. Excellent. So, Sue.
Yes, just to say, I'm pleased it's not actually unlike what we're supposed to be doing when we're teaching Pilates anyway. It's just a bit more detail. So it's not like a brand new technique, which is always baffling when you've been teaching a certain way for a long time. I'm pleasantly surprised it's along the same lines.
Good, excellent.
Yeah.
Me too. So the next bit might not be. So the next bit. What we're going to do is we are going to find a rhythm with our breathing. And we're going to do 3 breaths. And there's always 3 breaths here. And I'm going to talk through what we're going to do next before we do it. So we're going to do 3 nice slow breaths. At the end of the 3rd breath, we are just going to pause and do nothing at all. And that's the first thing we're going to do. And this is what I do with my clients to start with as well. The reason that I do this is called a breath reset. We're going to inhale and exhale, and I'm going to give you a lovely visualization to do with this as well when we do it. And we're going to pause, and we're going to take time just to pause between breaths. Now, the reason for this is that we want to make sure that our clients are really comfortable sitting with residual oxygen, but also with their CO2. So we're looking at working with our CO2 tolerance. If my clients cannot do this next exercise and pause for even 4 seconds, then I'm not going to take them on to teach them the apnea breath just now. I'm going to wait, and we're going to really work on getting comfortable between breaths, not breathing too fast, slowing our breathing down, getting comfortable with CO2 before I take them on to the next bit. Because if I try and rush taking them into the apnea breath when they're not comfortable having a break between breaths, then they're never going to achieve it, and it's going to feel really demoralizing for them. And the last thing I want my women to feel is demoralized. So we're going to first get comfortable with our CO2. The second part that we're going to do is we're going to do the same 3 breaths once we've had a few practices of the visualization. And then at the end of the 3rd one, we're going to pause. At the end of the 3rd nice, natural, slow exhale, We're going to pause for a moment. We're going to close our mouth and nose, and we're going to widen our rib cage exactly the way we did when we were inhaling. Widening to the sides, behind, and thinking about the sternum a little bit. And what's happening then is we're going to be working with residual oxygen in our body, and we're going to be working with the CO2. So this is called intermittent hypoxic training. We're not going to hold it for very long the first time, just hold it to where it's comfortable. We're always holding to where it's comfortable. The same with the breath reset thing we're going to do, we're looking at comfort areas. A lot of my ladies have done Wim Hof because it's very popular. I have also done Wim Hof. But Wim Hof is great for some things, it is not necessarily great for pelvic floors. So the issue with Wim Hof is that Wim Hof is about eliciting a sympathetic nervous system response in your body, a stress response in your body. Now, for pelvic floors to work optionally, we need our sympathetic and our parasympathetic nervous system to be working in harmony. Our bladder needs both to work together. If we've just got a sympathetic nervous system response, then our bladder is always going to be squeezing. And these women are the ones that need to go to the toilet all the time, you know. And if we've got a parasympathetic nervous system response, you know, and they're very much in what's called their dorsal vagal, then what happens is that they'll be more likely to have retention of urine and be unable to go to the toilet because they're just, nothing is functioning properly. What we need with our pelvic floor is we need the sympathetic to squeeze and the parasympathetic to release the urethra. And then we need the sympathetic to squeeze the urethra shut and the parasympathetic to allow the filling phase. So we need them both very much in harmony. So if we go for a stress response, or if our women try to hold too long in their apnea, they're going to put themselves into a stress response and they're not going to get the same effectiveness with their pelvic floor. Okay, so everything is within comfort, and that's really, really important. And I'm not looking for them to do a breath hold for like 2 minutes, ever. You know, I'm looking for them to do a breath hold to where it feels comfortable for their bodies. So let's try it out new with a nice relaxation. This is a lovely bit of any session I do with ladies. So we're going to lie back down again, find our neutral pelvis, our ribcage nice and heavy on the floor. If you do stuff with the Sue Hitzman stuff, it's like thinking about the spaces and masses. There's a lovely way to think about this. And then the head on the floor as well, making sure eyes are gazing gently up towards the ceiling. I'm going to talk about eyes a little bit later too. Okay, once you find that position, we're going to do 3 breaths, and you're going to focus on opening the ribs to the sides, behind, and that sternal movement, so the 3 deep breath. As you inhale, so I would like you to visualize this. I would like you to think about something now that brings you joy. So something, someplace, or someone who brings you total joy in your life. Okay, we're going to use that visualization for your inhale, because the inhale is the action part or the sympathetic part of our breath work. Now, I'd like you also to visualize something, someplace, or someone who brings you calm and peace. This, once you've got that in your mind's eye, this is what you're going to think about when you do your exhale, because the exhale is the parasympathetic nervous system's release. So we're going to do 3 breaths, inhaling joy, exhaling calm, and at the end of your 3rd breath, you're just going to pause and do nothing at all. You're just going to hang out in that space between breaths, and you're going to listen for your body's own natural impulse to breathe. Okay, take it away when you're ready. 3 breaths. Joy and calm. As you hang out in the space between breaths, relax your face, relax your eyes, relax your shoulders, relax your hands, relax your feet. And once you've done it through once, I'd love you to do it through again and just really feel comfortable with it before we move on. Now, when I'm doing this with a client in the room with me or online, as they do this waiting between breaths, I count in my head, like 1, 2, 3, just to see where they're at. And if immediately, you know, if they go into this space where they've got this calm and they're waiting, and they literally wait 2 seconds, then this is what we're going to be working on as part of our practice for the first session and for their practice at home. I'm not going to introduce the apnea for them yet. And when you come to the pause, it's relax your face, close your mouth and nose, relax everything. Japan. Good. Okay, so now you're going to do the same thing. Inhaling your joy, exhaling your calm. At the end of the third one, you're going to close your mouth and nose the same way we just did. You're just going to take a moment and you're going to widen your ribcage to the sides and behind, as if you were taking a breath, but holding the air out for this moment in time. So you're just widening to the sides. Sometimes feeling your ribcage helps, so making sure you can have your hands around your ribcage, fingers to the front, thumbs to the back. And do it through twice. So take 2 times to do it through, and then we're going to talk about how it feels in your body for a moment, and I'm going to give you some troubleshooters. Think about the inhale joy, exhale calm as well. There is a reason for that. And you're initiating the movement for the apnea breath from the rib cage. So you're holding the air out and the movement is starting and completing from the rib cage. So this is where it marks a difference from the Uddiyana Bandha. You might feel that your belly button's drawing in, you might feel like your abdominals are drawing up, but they're doing it in a response to what you're doing with your rib cage. As you do the apnea as well, I'd like you to make sure the back of your rib cage is on the floor. So we're not flaring forward, we're widening. Good. Now, a big one for quite a lot of women is that they hold too much tension in this area at the end of the third exhale. So they've exhaled and there's too, you know, the transverse is contracted too much, the obliques are contracted too much. So what I'm going to get you to do is do the same thing, but this time at the end of the third exhale, you're going to close your mouth and nose, and then I'd like you to release your abdominals a little before you widen your rib cage. So again, exactly the same thing. Inhale joy, exhale calm, times 3. And at the end of that third exhale, you're going to close the mouth and nose, just take a moment, pause for a moment, and release the abdominals a little, and then widen the rib cage. Make sure the back of your ribs are on the floor. Good. Once you finish this one, then we're going to have a chat about how this is feeling in your bodies. And if you've noticed that, and then I'm going to go through some troubleshooting ones I use with clients with you as well. Because not everybody finds this immediately, because it's a very weird thing to do. So it's just, yeah, it becomes really instinctive really quickly, but it takes, you know, the initial opening of the ribcage can sometimes totally outfox us. Jotty.
Hi.
Hi.
Yeah, no, that was interesting. I'm not really sure I'm doing it right at all on the second version, but I do feel like I really need to yawn a lot. So I'm wondering if I'm kind of getting breath, but the feeling of not breathing, sort of holding it, actually felt fine for quite a while, but I'm not sure. Yeah, probably a lot of things going on there.
So the yawn is a vagal release. So the yawn comes from a release of the vagus nerve. So and it happens a lot during breath work. So and a lot during this. I used to think people were really bored in my class to start with. You know, when I first started teaching, it's a yawning or need to yawn all the time. But it's a vagal release that's happening. So yeah. Do you find that just when you're going into the apnea?
Yes, it was more on that second stage than the initial simpler breathing. Yeah. But it sort of feels like I hadn't quite got enough breath in. And even when I went back to the sort of breathing in joy and the breathing out of calm, I still felt like I kind of maybe wasn't getting quite as much breath. I'm absolutely a chest breather. So
it might take a while for your muscles
yeah.
to used to this way of breathing as well. But it's also I was going to where was I I'll come back to me. I've got so perimenopause brain just now. I keep losing words. I'll come back to me. But yeah, to start with, the releasing of the abdominals isn't a cue that works for everybody. But for the women that I have who are quite tight, who do like things like CrossFit and things, who are like really tight in their abdominals, they just instinctively go to a position of tightness. So releasing can sometimes help to release their rib cage as well. But oh yeah, that's where I was going. So as we open the rib cage, I knew I'd get there, so it comes back quite quickly. So as we open the rib cage and the central diaphragm the tendon pulls down, the rib and the muscles widen, what happens with the epiglottis is it draws down. So quite often that can create this kind of massage at the back of the throat, which massages the vagus nerve that runs down the back of our throat, and that can create the need to yawn as well. Yeah. So it can be, and that will once the vagus nerve is much more functional and mobile again, then what happens is that initial need to yawn will go. Right. That's where I needed to go to.
Interesting. Thanks.
Yeah, I mean the breath work itself, you can actually add a more of a vagus mobilization to it by, instead of just breathing out with an actual kind of, you can add just a little bit of a to the back of it, and that creates a vibration in the vagus nerve as well. But I kind of come to that later on. Right. You know, I start people with a nice relaxed jaw, and I used to give everybody all the stuff immediately, and it's too much.
Thank you.
That's a pleasure. Any other? How was that in your bodies, Roz?
So I do the Wim Hof every day. So I start every day, every morning. It's the first thing I do is I wake up, and then I do the cold showers. But it was quite nice to do that way, because as much as I've been doing it, it's just I've done lots of reading on breathing with Stuart Sandeman and James Nestor and sort of Wim Hof, and so I've been doing that for 2 years.
Yeah,
and it's just given me a slightly different focus of how I'm doing it. So I feel better, I think, now doing it, if you see what I mean. Yes. I feel like I'm more aware of what I should be feeling in my body.
Yeah.
But I know that doing the Wim Hof, sort of, obviously I've been teaching for a long time, and I think we all feel it towards the end of a term or whatever, you get that tired voice, and I don't get that anymore. Having done the Wim Hof now for 2 years, you know, my voice is much stronger when I'm teaching. Yeah.
Oh, there are loads of bonuses to it. It's just that, yeah, it's for the demographic that I teach with pelvic floor dysfunction, the Wim Hof isn't necessarily going to tick their pelvic floor box very well.
Yeah. Yeah.
And it has loads and loads of benefits. It really, really does. I'm a firm champion of Wim Hof as well for breathing. And all the breath methods, you know, there's lots of things to be said for all the different breath methods, but they're all there for different reasons almost. So it's about finding what suits the client in front of you. That's important, yeah. But no, I totally love it, yeah. I'd stop the cold showers when yeah, that's different.
The cold showers, I must admit, 2 years on, is still a challenge every single morning. This morning I got in and go,
I've got the ocean like 10 minutes away, so I tend to do that instead. So yeah, but even then it's too cold at this time of year still for me. I have friends who are going in naked now, but I'm not me. So yeah, so anybody else with their bodies, because we're going to go through the apnea again with a couple of other tweaks to it, so we make sure we're all getting it right in our bodies, and I'll look at people who need me to look at them too. Anna.
Can I just check? So when we were in that resting period after the 3 breaths, and then we're trying to widen into the rib cage, but without intaking more breath, I was struggling not to get my abs engaged. Felt that was the way that I could do it. Is there any other ways for trying to switch that off a bit?
They will engage, but the stimulus has to be from the ribcage. But yes, sometimes what we try to do is try to use our ribcage to open our abdominals to open our ribcage. That's a really common one.
Right.
Yes,
okay.
I've got some cues that I'm going to give you shortly that will
that's
hopefully help. Yeah, but the other thing to remember is if you do when you do start to widen your ribcage, your abdominals are going to get involved because your abdominals are attached to it. But it's just making sure they're not the stimulus. So
that's it. I remember sort of groping around and thinking, oh, I can't get one without the other, you know, mentally. But yeah, okay, thank you.
I'll give you some visualizations that I give to clients. But sometimes they get far too wedded to. So we're going to go through why you not going to get wedded to them either.
Great, thank you.
Pleasure, Anna. Anybody else? How is that in your bodies? All good? Okay. So, a lot of the time people will have absolutely, and I was exactly the same. How the hell am I going to open my rib cage? What the hell am I doing? So what's actually happening is as we start to widen our rib cage, our intercostals between the rib cage are one set are contracting to help open it, while the other set are opening to help spread it wide. So we've got 2 different things going on. We've also got the serratus. So the serratus is a massive player in this. So your serratus anterior here is actually helping to open your rib cage. So it's the serratus doing the opening, and the intercostals doing the opening, and a cool set of intercostals that actually attach the back of your rib cage to your spine here and up here. They're doing all the work. So it's not coming from your abdominals at all, it's coming from those sets of muscles. And there's a little bit of lats in there as well, but we don't want the lats to get completely involved with breathing. We're more for serratus and everything else. So I give my ladies some visualizations to do. So the first visualization that we do is that releasing of the abdominals, which we've done already. The second one that we do is that we're going to do the 3 breaths, and at the end of the third one, we're going to close our mouth and nose and hold the air out. And then we're going to visualize having a straw and trying to suck a strawberry out the bottom of a glass of, I don't know, champagne, whatever you're going to do. But it's not that kind of sucking with the mouth it's that sucking that you have to do to lift something out of liquid without getting liquid in your mouth. So it's that. And you'll feel it if you visualize that, close your mouth and nose, just inhale and exhale. Close your mouth and nose and think about that movement. So you're actually doing it a little bit, but without breathing in. You'll feel your serratus wanting to get involved. So not taking in it, do it with air first. So do it with the air. Do it with the idea of sucking through a straw first. So do an inhale, exhale. Not all of them work for everybody, yeah? And then do it with air. You see how sucking through a straw gives that extra little engagement through the serratus? Vanessa?
I can't do it at all without drawing in air. I think that's why I was having trouble with the apnea as well. I struggle to do it without breathing in, but I got it eventually. But I can't do that sucking thing.
So try it lying down and just try it out, because to be honest, it doesn't work with all my clients. So this is one that works with some. So you've got some arsenal to help, and you just sometimes you just go through every single one till you find one that works with people. So you're going to do your 3 breaths, and at the end of the 3rd one, you're going to pause, close your mouth and nose, and visualize the idea of what we're looking for is just that initial activation, so that people can feel where it's coming from in their bodies. This one might not work for you, though. Sometimes people are just like, oh, this is amazing now. But other times they're like, oh no, this isn't working. So the second one, yes, Ross?
Can I just ask, so just because Vanessa was just saying that she was struggling to feel it, but Vanessa had said that she'd had the surgery on her spine.
Yeah.
Will that make a difference because of that surgery? Because she's probably a bit more fixed through that thoracic.
It might make a difference to finding the apnea to start with, yeah. But if the visualization is right for her, it wouldn't make a difference, because it would be activating the right areas. But not every visualization works for everybody. And I'm going to talk to you also about people who can't visualize. So I've had quite a few who are phasic, who can't aphasic, who can't visualize anything at all, which is also a little bit more tricky when quite a lot of my stuff's out around that, yeah.
I think it's mind over matter for me. Yeah, it's like you say, it's finding the right visualization, that isolation of it, and that's probably not what I practice. I've lost that connection, that area perhaps a little bit.
Agreed.
I can only do that if I draw the breath in.
Yes, so we don't want you to draw the breath in, we want to hold the breath out, yeah.
I
So
can't
let's do another
get
one.
it without, yeah.
Let's try the other one. So the other one is to do exactly the same thing, 3 nice slow breaths, because we're building up the residual oxygen in your body, so the hypoxic breath part is much easier. And then I'm going to get you to try and think about sniffing a flower without taking in any air. So it's almost thinking that you've got a slightly blocked nose. So you're trying to sniff something through a slightly blocked nose. So 3 nice slow breaths. Take your time with your breathing, widening the rib cage. That's it, How did that feel for people? Don't worry, I've got loads of them. So.
Got that one.
Oh, that one, good. So, and there'll be another one that works for somebody else, you know. So, yeah. How is that in your bodies? Okay. Vanessa, how is that for you? Don't worry, I've got some more stuff. It's not all visualization either.
I felt like I was doing it, but I wasn't 100% sure that I wasn't drawing in a bit of air still. I think if I envisage sniffing or sucking in, it just brings the air aspect into it. I think I might need to just not visualize anything.
I'm gonna come back to that. Yeah.
Just focus on the movement.
Yeah, we're going to come back to that one just now, actually, as well, coming back to the movement rather than the visualization.
Yeah.
Now, the blocking the air off one, the way I used to teach this sometimes with people, which I don't do so much now unless it's really desperate and that they're getting really frustrated over it, and it's just, is that you can hold your nose. So you can do your 3 nice slow breaths. At the end of the third one, you hold your nose and you do that sniffing through the flower, but hold your nose. So you can't take in any air. Now the issue with this is that we're going to bring in arms, and they're really important. And if you're wedded to holding your nose in order to get the apnea, it then becomes an issue. But let's try it with the holding the nose, because that's also another strategy for you to use with people. So you're going to do your 3 nice slow breaths, close your mouth, nice gentle exhale. There's no forced exhalation. We're going to look at the forced exhalation and the other way of doing this in a moment. So we're looking for an active stretch of the ribcage, and that's where we're aiming for with our practice. So 3 breaths. The end of the third one, close your mouth and nose, hold your nose. And then I never liked this one, but loads of my ladies used to like it. I used to have swimming pool things that you put on, you know, swimming nose clips. So they could still use their arms. They just did all the breath work through their mouths. But I think it's much easier if we can manage to find it in our own bodies. How's nose holding for you all? No, yeah, some people liked it, some people didn't. This is always the way it is. So the next one is to actually have some tactile touch. So for this next one, what we're going to do is tactile touch. So we're going to get, so you don't have to have, it's better if you've got skin, your hands on skin. So we're going to do our 3 nice slow breaths. At the end of the third one, we can have our hands around our ribcage while we do the breathing. At the end of the third one, we're going to close our mouth and nose and pause, and we're going to start widening our ribs, and we're going to use our fingers. We're going to move our fingers up in the way that we're wanting to move the muscles. So we're really focusing on that tactile touch, and touch is such a powerful thing that quite often this is the one that will hopefully help. But I've got others, don't worry. So even if this one doesn't work, we've got loads of others. So 3 nice slow breaths here. So taking your time with your breathing, inhaling and exhaling. And at the end of the third one, you do that nice pause. Maybe release the abdominals a little if you feel they're a little bit tight, and then use your hands. You're just moving in the way that your ribcage would move, and it's okay. How did that one feel for people?
That was quite nice. I could feel that I was really getting the movement, I think, yeah, to have that actual touch, yeah.
Okay, so the next one is to actually manually use your hands. So what we're going to do is, quite often with opening the rib cage, there's so much tension underneath the rib cage itself that sometimes it's the fascia and that tension in the fascia and that dryness in the fascia that's stopping us from being able to open our rib cage. And it will be impeding our inhales and our exhales as well. So we're going to do another little test that I do with my ladies who are like really struggling. I'm like, maybe there's something going on with tension underneath their rib cage. So what we're going to do is this. We're going to use the left side, not the right side of our ribcage for this experiment to start with. So we're going to inhale, and as we exhale, I'd like you to see how far underneath your ribcage you can get your fingers. So I'd like to know whether you perhaps, we'll talk through it after you've done it. So you're going to take a nice deep breath in. It's easier to do this while lying down, because if you sit up, your diaphragm uses a postural muscle as well, so it's not quite as relaxed. And then you exhale. Try and get your fingers underneath your rib cage. So when you do this, If you can't get your fingers underneath at all, it tells me that the fascia here is incredibly tight and dry, which means that we're going to have to work on releasing the fascia before you're going to be able to get a proper rib opening. If you can get your fingers under a little, so that's turned. When you can't get your fingers under at all, it's turned to 3. If you can get your fingers under a little, it's a 2. If you can get your fingers under quite a lot, but it's a little bit uncomfortable, it's a 1. And if you can get your fingers all the way underneath and kind of play your rib cage from the other side, then it's a 0. So, and it means that if I can get my fingers right underneath, it means your diaphragm's really mobile and the fascia is really great. So, thinking about where that's at. So, what we're going to do is give it a little release. I'm going to do both sides of our body. So, we're going to start at the solar plexus, but we're not going to push on that wee icky bone, whose name I always forget at the moment. I'm just going through a period of forgetting what it's called. So there's a little bone there, and if you press on it, it makes you really want to feel quite sick. So we're going to do just to the left of that bone. We're going to inhale, and as we exhale, we're going to slide our fingertips underneath our ribcage as much as we can, massaging all the way down. If we find a bit that feels tight or tense, we're going to inhale again and exhale and just allow our fingers to sink a little bit deeper into that area. And then we're going to inhale and exhale and massage even further around, coming as far around your ribcage as you can. And once you've done one side, you're going to swap and do the other, being mindful that on the right hand side you've got your gallbladder about halfway down, so that might feel a little bit tender, so just going carefully when you go past it. So just nice and slowly with the massaging. And then once you've done the massaging of your ribcage, you're going to hold your ribcage, have it in your hands, and you're going to do your 3 nice slow breaths again. And then when you do your apnea, I'd like you just to place your fingertips lightly underneath your ribs and think about them being separated and drawn apart, away from each other. So we're doing a little bit of a manual manipulation of them. So we do our 3 breaths. At the end, we close our mouth and nose, pause, and then think about widening. Start to think about them stretching towards the side, and just use your fingertips to help widen them. Good. How did that feel in all of your bodies, that one? We've got something else we're going to do in a minute. Good. So sometimes it's a tension underneath there. Now, there is the idea for a lot of women and a lot of my clients that they're like, how my rib cage needs my breath to open. It just does. I can't do it any other way, Abby. And I'm like, well, they work as separate things. No, they don't. Like, right, well, we're going to teach them to work as separate things then. We're going to teach your head this. So we're going to come to a sitting position for this one. And what we're going to do is something that this is just to get you to work out that your rib cage works independently of your lungs. It's not for regular practice, and that's really important. Because I've had some clients go in and they come back and go, oh, it's been getting really tiring doing that breathing. And I'm like, and they show me, and I'm like, no, this is just sometimes there's no listening. So what we're going to do is this. We're going to inhale, and we're going to keep our rib cage open as we exhale. So we're going to keep it open. Then we're going to inhale again into our already open rib cage and try and open it a little bit further. And then we're going to exhale, keeping our rib cage open. Then we're going to inhale into our open rib cage, and as we exhale, we're going to close our rib cage really hard down, like really close it. And then we're going to close our mouth and nose and widen our rib cage. So we're looking at 1, disassociating the breath from the rib cage opening, and 2, we're looking at using a recoil to help you feel what your rib cage is capable of. So, and this is where we're going to come back to the other type of breathing that sometimes is taught for hypopressives. So, we're going to inhale. So take your inhale, think about widening all the way around. Exhale, keep that rib cage wide. Inhale into your wide ribcage. Exhale, keep it open. Inhale into wide ribcage. Exhale, close, close, close. Close your mouth and nose, recoil. How did that feel in your bodies? Okay, so that's really good for disassociating. Now, in IHC and in low pressure fitness and with Marcel, we all teach what's called an active stretch, which is what I've been teaching you, that widening of the rib cage during the apnea. And we're going to have a last practice in a moment before we break for lunch of doing it as slowly as you can. And I'm going to explain why we need to do it slowly and not quickly in a moment too. The other way that this gets taught is this. We do a really fast breath. So we're going to inhale. So I'm teaching you to do it nice and slow, and I'm going to explain why before we break for lunch as well. The other way that this gets taught a lot is with a really fast breath. Inhaling for 2, exhaling for 4. And at the end of the last exhale, you close your rib cage as tight as possible, and then you allow the recoil to happen for the apnea breath. And it's a really fast recoil. And I'm going to explain why this is not necessarily the best thing for your pelvic floor in a minute. But let's try it. So, because it's good to try every different version. So I'm going to count your inhales and exhales so you can feel it in your bodies. Yeah, so we're going to inhale for 2, exhale for 4. Last exhale, we're going to exhale all the air. And the cue I hear from people is exhale all the air, which is a bit of a misnomer, but we're going to exhale all air, close our mouth and nose, and allow the recoil to happen. So ready to inhale. In, 2, out, 3, 2, 1. In, 2, out, 3, 2, 1. In, 2. Exhale all the air, squeeze all the air out, close your mouth and nose, recoil. Okay, so this is a recoil rather than an active stretch. Now, the reason this is not necessarily great for your pelvic floor or anything like that is this. If we come to lying down just for a moment, and I like you to exhale all your air out as much as you can, instead of going to a natural exhale, I'm getting you to lie down because it's not so much pressure on your pelvic floor if you're lying down. So you're going to take an inhale into your ribcage, nice and wide, inhaling. And then I'd like you to exhale, and I want you to really hard close your ribcage and push all your air out, really push out. Forced exhalation. And I'd like you to feel what that does to your abdominals, lower abdominals, and your pelvic floor, and your back. Can you feel that increase in pressure? Yeah. Forced exhalation. Yeah. Okay, so quite often, if you're somebody who's trained your abdominals loads, you might not necessarily feel that. But for women who have a dysfunctional pelvic floor, that will create a massive increase in pressure. So, which is one of the reasons why we don't teach a forced exhalation or closing your ribcage really hard all the way down, because all it does is it increases the pressure down towards the pelvic floor and the abdominals. Now, the other reason is this. If we're doing things really quickly, so if we're breathing really quickly, we are going to create a more sympathetic nervous system response. If we're breathing really quickly, the deep transverse muscle, our pelvic floor, our multifidus muscles, these are all slow twitch muscles. They're made up of predominantly slow twitch fibers. The difference between a slow twitch fiber and a fast twitch fiber is this. A fast twitch fiber tires much more quickly. A slow twitch fiber takes longer to tire. The reason our pelvic floor and our thoracic diaphragm and our transverse are all predominantly 69 to 75% slow twitch fiber is because they're never off. They're always on. They're on for breathing, they're on for sleeping, they're on for standing, they're on for pelvic floor function. They're always on. If we do that really fast breathing, we're only going to be talking to the sympathetic nervous system and those fast twitch muscles. If we do a recoil for our ribcage opening or open our ribcage really fast, we're also only going to be activating the fast twitch muscles in our body. If we take a long time over inhale and exhale, we're going to be integrating into our slow twitch muscles and starting to activate them. if we take a really long time to open our ribcage during the apnea, or the longest time we can, so we want to get to the end of our ribcage opening when we're ready to inhale again. So we're not holding the ribcage in this extended position for the whole time. What we're going to do is we're going to activate more of those slow twitch muscles in the pelvic floor and the transverse and the diaphragm. So what I'd like you to do now, we've done that recoil one, is I'd like you to lie down again, and you're going to take 3 of the slowest breaths you've ever taken. I'd like you to, but comfortably, so you're not going to, it's not in discomfort. I'd like you to try and exhale for twice the length of time you inhale for. So a really lovely, gentle, long exhale. And at the end of the third one, you're going to pause, close your mouth and nose, use any of the systems that worked for you for doing an apnea, and slowly widen your ribcage. Take as long as you can. Long, long, long. Okay. So a lot of time people ask me why they need to do the rest breaths in between, the 3 rest breaths. Why can't they just do the apnea? And the reason the 3 rest breaths are so important is because the 3 rest breaths are starting to teach your body how to breathe effectively throughout the day. They're also there to build up the residual oxygen in your body so that you can maintain a really comfortable apnea breath for as long as possible. They're also key to strengthening your posture, strengthening your core, and getting your pelvic floor to work in a functional way. As we inhale and widen the ribcage towards the side in our rest breaths, our pelvic floor is widening as well. As we exhale and close our ribcage back to its natural resting position, our pelvic floor is coming back to a natural resting position. This is helping to increase the resting tone in the pelvic floor and the core and the diaphragm. And this is super important. We don't want women to come back to tension. We want them to come back to a great resting tone. Then when we do the apnea, and the apnea is widening, there's a cool fascia connection that goes on that creates a visceral traction that pulls our pelvic floor up. So as we do our apnea breath and widen our ribcage towards the sides, we're increasing the volume in the thoracic area, and we're increasing the pressure in the thoracic area. Now, remember, we can't change the pressure in our body, but we can shift it about. So if we're increasing the pressure in our thoracic area, that means the pressure in our pelvic area, in this lower area, our abdominal area, that's the word I'm searching for, has to decrease, because we're not suddenly getting more pressure to play with to increase the pressure here. So as we create more volume in the thoracic area and increase the pressure in the thoracic area through the apnea breath, what happens is that we've got visceral fascia, which we'll talk about in more detail. And this visceral fascia is called the parietal fascia. What the parietal fascia does is it decreases the space in the intra-abdominal area. And when it does this, it draws the pelvic organs up with it. So we get this beautiful, gentle drawing up of the pelvic floor organs through the fascial connection between the diaphragm and it's the parietal fascia that goes all the way around from the diaphragm to the pelvic floor. So as it draws up, then it creates engagement in the muscles as well. So we have this beautiful synergistic movement that happens as we play with the pressure in our bodies. Any questions about that before we go for lunch? I'm sure there'll be some afterwards. You had time to think. But yeah, how is that in your bodies? Any questions?
Abby, do people ever get quite panicky when they do that? I can see that it could, you know, make people feel a bit uncomfortable. And how do you deal with that?
So that's why I start them with that rest breath at the beginning, Anna. I don't move them on until they're really, really comfortable sitting in that space between breaths. Because that's what used to happen. People would get really kind of, you know, and they'd be really unable to do the apnea. The other big thing with practicing the rest breath like that, where we do the 3 breaths and we just sit in the space, is because a lot of people have had bad experiences with breath. You know, perhaps they've had near drowning incidents, perhaps their brothers tried to suffocate them with a pillow. I've had all these have been all women that I've met, you know. Perhaps they've been strangled, or, you know, there's been some sort of abuse. There's all of these things come into play when you start working with breath, and it all comes out. So if you start with that nice, beautiful rest breath, and then they're uncomfortable with it, then the conversation can come out, and you can say, you know, you're only ever going to comfort. You can breathe whenever you want. You're in charge of this, you know, so you're empowering them. You're giving them the autonomy to be able to do it. You know, you don't have to hold for ages. You can hold for a little bit, and you build up their confidence in it.
That's really nice. And I like the fact that when you, even just with the breathing, you had really positive associations with the joy and then the calm, and it was all just a nice place to be. Yeah.
Yeah, that was completely nicked, by the way. So a lot of my visualization, I'll tell you where that's nicked from, because it's a really lovely book for you to read about people's nervous systems and about how to find a place of safety for them. So it's a book called Anchored by Deb Dana, and it's an amazing book, and I should get like money for the amount of times I recommend it. But it is such a beautiful place to start with the whole idea of the polyvagal theory and of sympathetic and dorsal vagal activation. You could read the actual book by Stephen Porges, but it's quite dry. Deb Dana, which I have read it, but Deb Dana gives you a really lovely, she's basically translated it so it's nice, you know, and it's easy to understand, and she's got lots of exercises in there. And this one is, the rest breath is actually from my breathwork training, but then I put Deb Dana's like visualization into it. It's a mix of things, but it's a lovely way for people to feel safe, and we want people to feel safe. And the thing with hypertonic pelvic floors and women who have painful pelvic floors, who I see a lot of, vulvodynia and all these things that create pelvic floor extreme tightness, the majority of women unfortunately have this because they have been through some sort of abuse. So it's very important that we're really aware of the fact that the breath work that we do and that the work with the pelvic floor to release it might trigger that response in them. So making sure they're really comfortable and really in charge of what they're doing is really important. I've been to so many conferences on pelvic pain, and it's a scary figure. Like 85% of women with vulvodynia have been through sexual abuse of some kind, or corporal abuse, or some sort of childhood abuse. So it's really important that we speak to them in a really nice way for their bodies. Yeah, on that note. So yeah. Any other questions about what we just did?
Yeah, just briefly, because of the increase in thoracic pressure with cardiac issues, it's the same sort of contraindicated stuff for them, I guess.
So yes, contraindications. So we should have done this at the beginning. I always do this at this stage because sometimes I ask, I go, she does right at the beginning. So in your workbooks that you all got sent, it has contraindications. It has a big list of them now of contraindications. So contraindications are heart surgery. So anybody that's had heart surgery, and the reason is because we're increasing the pressure in the thoracic area, and we're not increasing it by a major amount, but I want to be very, very careful with people and look after them. So they can do the breath work and they can do the poses, which in turn creates a much more functional pelvic floor. The apnea is like the icing on top of the cake. The other ones that can't do the apnea breath are people with ALOS, DANLOS, vascular. So vascular ALOS, DANLOS is when even the arteries and veins are hypermobile. And so we really don't want to put that. They know they've got vascular. Usually vascular ALOS, DANLOS comes along with POTS as well, which is tachycardia. So they have heart palpitations, and it comes along with a whole heap of other things as well, generally. So they generally know that they've got that. Women sometimes don't know they're hypermobile, but they do know that they've got ehlers-danlos vascular. The other one is COPD. So the breath work is amazing for COPD, but it is contraindicated for them to hold without air with COPD. The other one is IBS and Crohn's during a flare. So during a flare, when the abdominals and the digestive system is all inflamed, we're not wanting to squash it and squeeze it and pull it about. We want to leave it to rest. But the breath work during a flare is brilliant for calming the nervous system down and helping with the flare, so they can still continue their practice. And all my ladies who've had these issues, or ulcerative colitis, anything like that, when they've got a flare like that, my women with issues with this, over time of practicing, they've had fewer flares in their conditions. All these autoimmune things are quite often tied to stuff going on with your nervous system. So once we start to calm the nervous system down, quite often it really helps. It doesn't completely remove it, but it helps. And the other one's pregnancy. So that when a woman finds out she's pregnant, she stops doing the apnea. If they find out at 8 weeks that they're 8 weeks pregnant, there's nothing to worry about. It's so tiny then that it's not made an impact, you know. I had one of my clients came and she's like, I keep getting this really weird feeling here when I'm doing the apnea. And I was like, are you sure you're not pregnant? She said, no, I'm not pregnant. I'm definitely not pregnant. And then she came back next week and she's like, oh my God, I'm pregnant. And it was actually twins as well, you know, so it wasn't just one, it was two. But she carried on throughout her pregnancy, and all my ladies who've been pregnant carry on throughout their pregnancy. And the breath work helps to keep their rib cage so they don't flare forwards. They have this beautiful wide open rib cage. They've got lots of space for baby. Their psoas stays nice and supple, and this means the baby sits further back, which means they've got less incidences of diastasis afterwards and pelvic floor dysfunction. The psoas also in the birthing world, they talk about it being like the runway for the babies to be birthed. So if your psoas is really tight and your rib cage is flared to the front and everything's like here, and you've got this big lordosis happening and you're really anteriorly tilted your pelvis, your psoas gets incredibly tight, which means that it can no longer guide the baby out properly. So we want to have as supple as, I wish I'd known this stuff before I had babies, eh? You want to have as supple a psoas as possible in order for the baby to be able to find its way out. It is like our own natural runway system. But the majority of us end up in a really lordotic position, which we'll talk about when we come back after lunch. Any final questions? Happy days. Come back with loads. I'm happy for questions. So we're back at 1:30. Yeah, it's good, Wendy. We're just finishing. So we're back at 1:30. I will see you then. Don't eat too much for lunch. We are going to do a little bit of slides, and we're going to look at postures and active stretching before we add the apnea back in. So don't worry, you can eat lunch though. Okay. I will see you soon. Yes. Emma.
What time was that again? Sorry.
1:30. So we're 12:30 now. Yeah, 1:30. Cool. Excellent. I will see you all then. Mwah. On. Paused it. A couple of minutes before we get started back. But if any of you who are here have any questions, please feel free to ask. I got some sunshine in Scotland. It was mental.
Feels so shocking, doesn't it? Just it's been such a difference.
I know, it's mental, isn't it? Oh yeah, my kids are still inside playing computer games, but you know, hey ho.
Can I just ask Abby, so if somebody's got scoliosis, is that very much going to affect this? Because obviously their breathing isn't going to be equal bilaterally.
No, but over time, using the bilateral movement and the poses, actually, in the full level 1 training, we go into scoliosis quite a bit at the end as one of the pathologies and that are helped by hypopressives. Tamara did a study on teenagers between the age of 11 and 17, I think it was, and she worked with kids who were using the Schroth technique, but also hypopressives, and then Schroth and hypopressives together. And it actually, with Schroth and hypopressives together, really worked really super effectively. And you can see the spine actually shifting and changing shape as the muscles start to work together bilaterally.
Right.
Yeah.
Because I've got a client and she's got scoliosis that has come on with sort of age,
yeah,
but she's now got a prolapse as
so this
well.
would work wonderfully for her. So
Right.
this would really help her.
Yeah.
It
Okay.
also works really well for other pathologies as well, like MS. I've worked quite a lot with MS. We've got an MS centre in Edinburgh, so I did training for all their physios, but I also did a couple of classes there, and I've had some clients with MS, and it works really, really well because the diaphragmatic breath is one of the first things to really be affected.
Right. And also I work with someone with Parkinson's, and
Yeah.
I've worked with him for years. So I do a lot of very away from my Pilates stuff with him, very much about his voice and stuff. And I was thinking actually this would probably be quite beneficial, wouldn't it, for him?
Yes, definitely. But I'd also look for the TRE for Parkinson's as well.
Right.
So that the tremoring, the it's one of the big things for them, that they're really looking into how that tremor response from Parkinson's is actually the body's way of trying to work something out.
Oh,
So,
really?
yeah. So it's, although it's not scientifically proven or proven to nice standards and things, it is definitely one of the areas that TRE suggests that you work with as well.
Right. Oh, that's really interesting. Thank you.
Yeah. But yeah, definitely Parkinson's and Huntington's. It's the breath work in this that's so effective for it because of that blood-brain barrier connection. And there's loads of research being done on it just now. There is a research paper which I can share with you guys when I send the video. So I'll just send you the link to the Huntington's.
Lovely.
Can I just ask as well then, on the back of that, would that have any impact on essential tremor?
Yes, possibly, yes. The TRE would, yeah. But also the breath work that we do here would as well.
Okay.
Yeah. I mean, the body has got such amazing ways to try and heal or to try and sort itself out, and we don't really know what those are. So things that look alien to us, we try and stop. We don't actually know if that maybe stopping them is maybe making it worse or better, or we try to make everything look normal, and it's whether that normal is where our body needs to be just then, or whether the response that it's trying to do is what the body's trying to do for healing. We talk about this a bit more in the fascia course as well, because of the lack of actually understanding of the insides of our body. Is we're getting more and more in the fascia world moves all the time, so we'll get to that. So, any other questions after lunch? Everybody okay? Perfect. Well, we're going to run through some theory, and then we're going to get back and we're going to do the poses that we're going to add in with the apneas. So we are going to fire on to sharing a screen, which will hopefully be a really great transition again. Play from current slide, that's what we want. And then I want to change this. Okay, so we talked about the different breathing patterns, and they're here written down for you to have a look at as well. So from the normal to the paradoxical to the apical. This talks a lot more about the transverse and the chest breathing. So again, for you to duck back into, but we did an experience of it ourselves. This can really contribute to pelvic floor issues hugely. I've put a picture of a guy here, so you realize that guys have got a massive problem with this, with the way that they breathe. And here we can see that kind of barrel chested, not much movement here. Then we've got our belly breathing, which we talked about as well. And then we've got the 360 lateral breathing. So this is what happens. This is a mock-up of what happens to your diaphragm when you use your rib cage. And if we see the crura, so the little tentacles that come down the spine here, those knit in with the psoas. So the movement of the diaphragm is critical to the movement of the psoas. So I'll put a wee note here as well for you to go back over and read as well. In 360 breathing, the diaphragm takes center stage, contracting downward to generate intra-abdominal pressure, driving expansion in the abdominal muscles and pelvic floor. This regulation of intra-abdominal pressure plays a preventative role against hernias, prolapse, diastasis recti, and back pain. All of this, we've got relaxation of the psoas when we do it, relaxation of the quadratus lumborum, which is a big thing that comes up with back issues, and the paraspinals when we're inhaling. And then when we exhale, we've got that active stretching of these muscle groups as well. The balance between all of these is crucial, especially considering that many individuals often experience tightness in the psoas, even though they don't know what it is, and QL and back muscles coupled at the same time with weakness in the core and pelvic floor. Okay, we're going a little duck dive into fascia here because we need to kind of know what it is I'm talking about when I'm talking about mobilizing it. So in a very kind of overview, that's much more complicated than this these days, fascia is a thin layer of connective tissue that envelops and supports various structures in the body. Now, there's a lot more to it than just being a thin layer these days. So this is an overview. This includes organs, blood vessels, bones, nerve fibers, and muscles. This tissue serves not only as a structural framework, but also possesses nerves. So the nerves run through the fascia. The other interesting thing about fascia is they've now discovered that most of our pain receptors live in fascia. So although we might fix the muscles, if we don't release the fascia, if we don't rehydrate the fascia, then the pain will still be there. So it's super important that we think about how we're going to mobilize the fascia, which we'll talk about in the next one. So this makes the fascia very sensitive, almost comparable to the sensitivity of the skin. When under stress, fascia has a tendency to tighten up. So if you think about it from just the neck, so this here, underneath our neck here, we've got a huge piece of fascia called the platysma, which is, it's like a necklace around our neck. And it goes over the nerves, which are also like a lace necklace here. So we've got this necklace around our neck, or we've got a lace necklace of nerves here, and we've got this necklace here of fascia. Imagine what happens when people get tense and tight. What immediately happens with them, they start to draw up through the muscles here, draw up through the shoulders here, and tighten the fascia here. And then we have issues with tight necks, tight shoulders, all this connective tissue that extends into our back muscles, our chest muscles, and our shoulder muscles becomes extremely dry and tight, and it won't let go. And so we hold pain there, and we hold tension there. So that's just one example of a big piece of fascia. So we're going to be looking at active stretching, and even in the static poses that look still, we've got a lot of work going on. So we're going to be looking at those in a moment. Fascia plays a crucial role in the body's functions with its diverse components. It maintains the suppleness of fascia. The suppleness of fascia requires varied movements. So we need to move it in lots of different ways, which is what we're going to do when we start mobilizing it much more. Initially, though, when we're teaching hypopressives, we need to get people to understand how to actively stretch and how to breathe and how to stand and how to hold their bodies before we add lots of active stretching in and lots of different ways to move the body. When disrupted or misused, fascial tissues may thicken, harden, or become blocked. Now, a lot of my ladies who have had C-sections and have a shelf, one of the things that they notice the most doing hypopressives to start with is not the change in their pelvic floor or the amazing changes that are happening in their posture. What they notice is that the shelf starts to go. And that's because the fascia underneath there has become hardened and dry, almost like a dam, blocking the moisture and the fluid going through and blocking the sliding glide of the fascia and the nerves and the muscles. So holding everything in this kind of tight line. When they start to do the breath work and the apnea, that starts to, it's almost like they're pushing the dam. So slowly, you know, if you're on a river and you've built one as a kid and your brother's built one, he's really proud of it, and you just start pushing it and pushing it and pushing it. And eventually, with enough pushing and mobilization, the dam gives way and the water comes through. It's the same, we're doing the same with our bodies. That's a really big overview. But so for them, what happens is the shelf starts to go. And it's like, hip, hip, hooray, because then they start to think about that part of their body belonging to them again. Because a lot of women who've had C-sections are like, above my C-section is me, and below my C-section is no longer me, because they don't identify with it. So what we start to do is we start to create this through line in their bodies. Okay, so unlike muscles, fascia doesn't respond well to force. Neither does your psoas, interestingly. Psoas needs to be worked really gently to start with. Instead, gentle, sustained stretching is key for inducing change. Engaging in multidisciplinary movements and stretching fascial tissue can effectively alleviate tension, stiffness, and pain. Okay, so we overview.
we are going to be doing visceral traction. So this is what I was talking about with the pelvic organs. So we can see in the images here, what's happening here is our parietal fascia that goes all the way around the top of our organs and all the way around this whole intra-abdominal area here actually starts to draw them up during the apnea. And we're going to see a visual representation of this in a moment. So be prepared for a full frontal of a pelvic floor in a moment. I am starting to warn people before it just comes on their screen. And they've got children in the background. So the use of active stretching of the fascia and muscle chains, I get sent pictures of people's vulvas and vaginas, so which I'd never thought would happen, but they randomly turn up on my phone, and you have learned that I've got to have a proper lock on my phone so my kids can't see it. So when combined with the apnea breath is increased, creating a vacuum. So it's the vacuum we're creating, but the vacuum is being created by the action of the rib cage. There's no active sucking in or pulling up. There's no Kegel type voluntary movement. Now people ask me, would I get more from this if I do a Kegel during the apnea? Now the answer is no, because what happens is as we start to widen the rib cage and the fascia starts to pull the viscera up, we want to have the pelvic floor and the viscera, that whole pelvic area, with a great resting tone. It's waiting to be drawn up. If we do a Kegel and tighten, then it's like having a rock that the fascia is trying to pull up. So now we've got a tight bit instead of a bit that's ready to be drawn up. So we don't want to create any sort of lock or hardness at the bottom. We want to make sure that everything is just ready to become part of the journey and part of the team. So we don't want to be holding back. We're not. If we do a Kegel, it's like our pelvic floor going, oh, I'm not sure if I'm going to move, not sure if I'm going to move, not sure, you know, we want it ready and able to move and function. We'll talk about Kegels. The engagement comes from slow, mindful, active lengthening and a slow opening of the ribs. That is held for as long as is comfortable for the person performing the apnea. In hypopressives, we have a series of postures we move through in a flow. However, the principles can be applied to other modalities too. So if our key postural premise is kept informed in the practice and the breath work, then this can be done in lots of different modalities. We'll talk about that as we go too. So, sit up on the pelvic floor. In this video, we're going to see a sit up and the pressure that it creates in the pelvic floor. Now, I'm going to put a caveat on this. You can do a sit up and this not happen to you, but you need to be able to co-activate your abdominals. There is no bad exercise, there's bad execution of exercises. And the issue is that most people who I'm going to strengthen my core, I'm going to get a flat stomach, they don't have the co-activation available to be able to do an effective sit-up. So I always put that caveat on because I really believe that there's no way, we shouldn't demonize any exercise, but we should understand that there are correct ways to do it. Okay, so this is our first one. So this is the bladder pushing out. I think it's actually uterus pushing out. Hold on. Go have a look at it. I've got a few of these. I'm just checking which one this is. So yeah, that's the uterus starting to push out through the vagina. And this is the sit-up one. Yeah. In this video, we are going to see a bladder prolapse during an apnea breath. So this is when she's got a stage 2 bladder prolapse because it's just at the labia at the entrance. And so we're going to watch what happens.
Abierta, haz un hipopresivo. Ponte en posición y haz el hipopresivo. Así. Respiro y luego eso es.
Just doing a slow opening.
Tira, fuerte, más. Aguanta todo lo que puedas. Cuando no puedas más, coges aire y relajas. Pasar. Muy bien. Ahora quiero que me hagas un abdominal normal o algún ejercicio de pilates. Así que puedes estar tumbada.
Now, initially, when you do the apnea breath, everything will draw up when you're doing it well. And as you do your next inhale, exhale, everything will start to lower back down again. The reason for this is that the body doesn't have the right resting tone yet within the musculature in order to hold it up. However, the more we do the exercises, the better the resting tone will become. The better the resting tone in the muscles, the more support the muscles give the pelvic organs, and the easier it is for your ligaments to remodel. Our pelvic floor is held in place by an amazing suspension of ligaments. It's not a floor, it's like a hammock. And the hammock is supported from above by ligaments that allow our pelvic organs to be in movement. They're not kept static, they're not kept solidly on the floor. They are a beautiful, harmonious symphony of movement. The issue comes when the ligaments become stretched or damaged, or the muscles become weak. And what we're doing in hypopressives is we're using our fascia and our visceral traction to draw the organs up to a place where the muscles can start to become better toned. The fascia becomes better toned. It starts to hold the organs up there more, allowing the ligaments time to remodel. If ligaments are being constantly stretched, if there's a full stretch, the ligament's not going to be able to remodel so easily. Ligaments take a really long time to remodel. They go through 3 phases of remodeling. At the end, the third phase is the remodeling phase. I have lots of people who are told by surgeons that their ligaments will never fix. You can't fix a stretched ligament. This is kind of true if it's a stage 4 and the organs are all the way out of the body, because there is so little, the ligaments have been stretched really beyond their ability to be able to recoil back up. However, I also don't ever say to people that it's not going to work for them, because I have had stage 4 people who've managed to get theirs to a stage 3 and been symptom 3. So that's when it's at this, just through the labia here, stage 3. So, and they've been symptom free and happier, much happier with where they're at. They use a pessary and they're great to go, and they've not needed surgery. So there's always, I always look at the holistic view first, and then if they want to go and have surgery, their tissues will be in a much better state to have surgery. However, yes, so ligaments, so when they tell me that, when they say there are surgeons, so the doctors told them they can't fix it if they have a prolapse, it's total bullshit. You absolutely and utterly can remodel ligaments and retone muscles, and we all know that. And it's no difference for these ones than it is for any others. They're also told if they have a levator ani avulsion, so an avulsion of the levator ani muscle means that the muscle has been torn away from the bone, which means that the muscles that make up the levator ani are no longer actually attached to the bone. You can have a partial levator ani avulsion, a full levator ani avulsion. You can have it on the left side, the right side, or both sides. Now, the issue here is they're told that nothing's going to fix, but these muscles that make up the levator ani are not the only muscles in our pelvic floor. And over time, over time with hypopressives, we create better resting tone throughout the rest of the muscles, who will help to support the weakness in the levator ani. So although we won't be able to fix the muscle back to the bone, we will be able to give these women better support from the rest of their pelvic floor. Surgeons also can't do anything for it. So they say, oh, you've got levator ani avulsion, there's nothing we can do. See you later. We can't fix that, we can't fix muscle to bone. So they're left with this kind of feeling of lack of hope. I've had lots of women who I've worked with who've had partial or full levator ani avulsions who have had amazing results with hypopressives. Okay. Oh yeah, we've seen that already. So female pelvic floor, to give you a bit of an overview, we have the bladder on the pubic bone, the uterus and the rectum, which then comes up and round past the uterus here. You can actually palpate or touch all of these from the front of your body. So you can actually, if you feel just above your pubic bone, especially when you need to go for a pee, you can press into your bladder. And just above that is your uterus, and just above that is your rectum, or part of your rectum. So everything's kind of facing this way a little bit. Now you can imagine that if we took away the uterus during a hysterectomy, we are going to be leaving a lack of support for the other two. So quite often people will go and have a hysterectomy thinking that it's going to improve their symptoms because the uterus is no longer going to be squashing the bladder. But then when we take it away, the bladder no longer has no support, especially if the vaginal walls are weak. So this is when prolapses can happen. post-surgery especially. So it'll either be rectal or bladder. Quite often when people are going for a hysterectomy, if they've decided that's a choice, I ask them to speak to their surgeon about having a stitch for their bladder and a stitch for their rectum, at least to hold it initially while they strengthen. So we can see how interconnected it all is, which is pretty cool. And this here across here, that runs across here, this pelvic floor muscle is your levator ani muscle. Male versus female, to give you an overview of male versus female, there is not a lot of difference. So this also really works really well for men, especially men who are having prostate issues or erectile issues or urinary issues too, which tend to come after prostatectomies. And again, you've got these in your sheets to have a look at in an overview as well. But they're really, really similar. We've just got fewer, they've got fewer orifices for things to fall into and fall out of. So our pelvic floor is not a solo operator. The pelvic floor has many hats. It's part of the breath system, and we use it for sex. We use it for stability, for locomotion. We use its support for internal organs. It's a sphincter and it's a sump pump, circulating lymphatic drainage. You can see here in the top picture here, this is supposed to have an M on it, it's multifidus. So you can see the connection between the multifidus, the pelvic floor and the abdominals, which is important for back stuff going on as well. And here at the bottom here, this is the levator ani here, these two muscles, the iliococcygeus and the pubococcygeus, make up the levator ani. So they come around the openings. So it's right here, just around the sphincters. Also here, the image to the left is to show you how connected the psoas is, how it comes straight through. So from here all the way into the iliacus here, and then out into the femur here. Pelvic organ prolapses. So these are lots of different types. The one type that's not here is a rectal prolapse, where the rectum actually comes out through the anus. The tissues come out through the anus. So enterocele at the bottom is more likely to happen if you've had a hysterectomy, because your uterus is no longer there to help support with the fascia. So it's if the fascia and the connective tissue becomes almost like a split in it, then the enterocele, the stomach lining, the lower intestines will have the possibility of coming out. This is quite rare. So this is one of the rarer ones. Cystocele is a bladder prolapse where the bladder pushes into the vaginal wall and comes out through the vagina, and erectocele is the other one that comes from the back. With erectocele, a lot of times women will have to, the poo pools in here, so they don't get the sphincter doesn't get the signal to poo quite often, or it gets stuck. And what they have to do is do something called splinting, where you put your fingers into your vagina and you push the back wall backwards so that you can go to the toilet. A uterine prolapse is where the uterus comes through the vagina. Any questions about any of this so far? Okay. Hypopressives works most effectively to start with bladder prolapse, because it's got that direct connection from the bladder all the way up through the anterior chain. It also works really, really super quickly for the uterine prolapse. Rectocele takes a little longer because we've got to work on really getting the multifidus joined in and all the muscles at the back. So it takes a little bit longer with the rectocele. Diaphragm. The diaphragm is a muscle that separates the abdominal cavity and the thoracic. It has connections through the body and creates activation in the vagal nerve, psoas, adrenals, anterior fascia chain, and the falciform ligament of the liver down to the bladder. As it moves, it massages the heart, the upper abdominals, and helps to mobilize the lymphatic system. So I think there's a nice video here for you to see it moving and its connections. Okay, wee short video. This one here, the grey matter, this one is here as well. See the grey matter here? That's the central tendon. So it's not a tendon like you imagine a tendon, like a long thin thing. It's a flat tendon. Okay. the role of the diaphragm. And this picture is here also to show you how connected it is to everything, like absolutely everything. A lot of people who have issues with their esophagus, they have esophagus here. If they've got a diaphragm that's not working properly, that's not got enough tension in it, not enough resting tone, then this can create an issue with the esophagus here, and that can create a hiatal hernia, where the tummy herniates up into the chest cavity. Hypopressives works really well for helping with hiatal hernias. You just have to keep people upright or supine to start with, and not in inverted poses. But we talk about that more later as well in the next series. The vena cava is the big blood vessel that goes through our body. So having a great functioning diaphragm helps to circulate the blood through the venous return. We've got quadratus lumborum here, psoas major, medial ligament. We've got so much going on here. So what does it do? It's for breath, stabilizing the trunk, places pressure on the esophagus to prevent acid reflux. Phonation for speaking, prevents herniation of the abdominal organs in the chest cavity, and the central tendon contracts as we inhale and exhale. So this white matter here is our big central tendon. So here, this is pictures here again, just to show you how connected everything is to each other. It's pretty amazing. Our body is like a big jigsaw. And then here to see just the effect that the diaphragm has on the pumping of our blood through our body. We do a lot of dorsiflexion in hypopressives, and there's a reason for this. This study that I've included in here for you to look at shows that the extra activation that we get in the transverse abdominis muscle when we dorsiflex our feet and then do the vacuum. So we get huge activation in the transverse when that happens. Every single one of our poses has ankle dorsiflexion in some form in it. So we get this extra activation, both of the posterior fascia chain and into this transverse muscle too. So it's here, and this works really well for low back pain as well. This study's about low back pain and hypopressives. So ankle dorsiflexion, I've put a wee bit in about this. Lack of range in the ankle can create knee valgus, poor pelvic and hip mobility. Increased range of movement combined with abdominal maneuver improves transverse abdominis activation, increased lumbar stability, increased hip range and better pelvic mobility. And that's what that study was talking about. So it's there for you to have a look at if you want to go a bit deeper with that. So there is a direct relationship between the tongue and the pelvic floor, and the tongue and the neck. And this is the connection. So if we see here, we've got the tongue, and then we go all the way down to the big toe. So we've got this connection through the fascia, through the entire body. So the more tension, it follows, the more tension that we hold up here in our tongue and our mouth, the more tension we're going to be feeling both in our feet, our glutes, our adductors, and our pelvic floor. So we're releasing a whole chain of muscles by relaxing our jaw. Okay, we're going to do a warm up for that in a minute too. The eyes as well, just out of interest for you guys, I go into much more detail in level 3. The eyes, which is all about nervous system in the eyes, behind the eyes is a receptor. So if we were to see a tiger or a lion, it would immediately, before we've even thought about seeing the tiger and the lion, send a message back through our central brain, our grey matter, to our pons at the base of our spine into the reptilian brain. There's a little kind of computer system that then sends a message all the way down our spine and tells our body that it's going to need sympathetic nervous system release and run. And it hits S1, S2, and at S1, S2, there is another little computer system that tells your body whether it's safe at the moment for you to poo or pee or do any of those things, which is why sometimes contraction at S1 and S2 can affect bladder continence. And then what it does is it switches off the bladder, switches off the parasympathetic nervous system so that we can really run for it. So our body jettisons things it doesn't see as being important for survival at that point. So making sure that your clients have soft eyes and that they're not like looking like, oh my God, what's she making me do, is really, really important for their pelvic floor health as well. And so just I always make people aware that they need to think about what's going on with their eyes too. Okay. We're also going to do a little bit of a toe warm up. Our feet, there are 250 to 300,000 nerve endings in our feet. The sciatic nerve ends up in your feet too. So do branches of your femoral nerve. So these ones feed your pelvic floor as well as the rest of your body. All your pelvic floor muscle, all your nerves from your feet all share the same nerve root as your pelvic floor. So S1, S2 into the sacral complex. And so if we can have mobile active feet, we can have much more of a mobile active pelvic floor. The other thing about feet is the position of the feet is super important. And we'll do it when we're standing, and we'll talk about that too. Don't worry, I'll go through these things when we get into it. I've got contraindications here, so the pregnancy and hypertension. So high blood pressure was one I missed. So if people have hypertension or blood pressure that is under medical control, so that it's in control, then they can do the apnea breath. But what I do is I get them to have regular checkups, because quite often they need to lower their medication, because as their body becomes more balanced, they have less hypertension. So we're slowly, hopefully, curing it for them. Okay. So apnea, we've talked about this, we've done it. So this is just to remind you and help you when you're looking back over it. This is my a really annoying 11-year-old who has a really beautiful apnea breath, which is why he features here and not me, because mine doesn't look this dramatic. This is troubleshooting for the apnea. You want to look out for you using the abdominals to try and lift. Sometimes the secondary accessory muscles are recruited, so the scaling, so people try to lift from above or they try and lift from below. Sometimes people flare the ribs forward instead of widening them all the way around. And sometimes they try to lift the ribs from the shoulders. We've done the helpful visualizations already, so these are them here for you to remember. And there's some notes for your apnea. And now we're going to go into the poses. So we're going to look at Demeter, Athena, and these have all got cues for you for afterwards, so you don't need to think too much about it. Artemis and Gaia and Maya and Hestia. Ta-da! And then at the end there's some questions I get asked. So we are going to move into a bit of a practical element now, and we're going to talk about all the muscle groups that we're using, hopefully, as we, well, kind of all of the activation that we're using, rather than going into every muscle group. One is, the big question that I get asked quite a lot is about the coil. So women are given the Mirena coil for perimenopause, menopause symptoms quite often. And the Mirena coil is tiny. There are lots of lawsuits in America with the Mirena coil migrating, i.e. moving to places in the body it shouldn't be. And this is not through hypopressives, this is just through normal everyday life. So I just bring women's awareness to the fact that there is always the possibility with a coil that it might move. But there's no cases of ever happening with hypopressives or Pilates or yoga or any of these things, but there is with life. So, and it's in the small print. So people ask me if they can do hypopressives with the coil, and I say to them exactly what I've just said to you. It's their choice whether they want to have the coil removed or whether they want to keep the coil in. But just to make them aware of the small print, and that Mirena is being totally sued in America just now. But these are some of the main questions I get asked. I've added a checklist at the back for you. So these are all the principles. So as long as these principles are adhered to or mentioned, then your hypopressive exercise will be effective in any modality. But we're going to go through them all now as well. And yeah, that's the same thing, going through them. And that's me. Da 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 da. Right, let's do practical. I'm going to open some doors. It's boiling in here. I'm not complaining. It's amazing. Okay. Any questions about all that we went through while we get set up for doing practical? Everybody okay? Right, we're going to start on the floor on our backs, and then we're going to move from there to the standing pose. So we're going to come first of all to the floor. I'm going to open my door. Put my dog down. Okay. So we're going to come back to lying on the floor, and we're going to come back to our neutral pelvis,
our ribcage heavy on the floor, the back of our head heavy on the floor, and our feet also on the floor. And we want our feet, our pelvis, our ribcage and our head to be evenly weighted. Now we're going to start activating this pose, and then we're going to bring the breath work back in. So the first thing we want to do is we want to start activating the posterior chain. So we're going to take our feet far enough away so we've got a kind of 45-degree angle with our knees, and then legs are hip distance apart, and we're going to dorsiflex at the ankles. So we're dorsiflexing at the ankles, and I get people to close their eyes and just feel when the muscles and the fascia and when they start to feel a connection or a stretch, that's where they stop. We want to treat it like a dimmer switch going on. We're going to be holding this pose for a while. So we don't want to be pulling back really, really tight so we feel like we're giving ourselves shin splints. We want to just be aware that as we lift them up, there's a point where you start to feel muscles and fascia engaging, muscles mainly. Okay, so at that point you're going to hold it. So what are we doing here? The first thing is we're starting to activate that deep transverse muscle through the connection between the big toe and the foot, all the way up through the transverse to the tongue. The second thing we're doing here is we're stretching the posterior fascia chain. So as we draw up here, we are starting to tighten the fascia chain that starts underneath our feet and goes all the way up through the back of our body, all the way up the back of our neck, and all the way into our eyebrows at the front. So as we dorsiflex, we're just adding a little active stretch of that fascia chain. And you, the dog, will try and that open the door. Good. Now from here, keeping that active stretch, I'd just like you to do 3 nice slow breaths and an apnea. So holding that active stretch now, 3 nice slow breaths and just a short apnea because we've just broken for lunch. So just a wee one. So inhale, you can inhale joy, exhale calm, or you can just widen the rib cage and then close the rib cage. Inhaling through your nose, exhaling through a relaxed jaw, or exhaling through your nose with a relaxed jaw. And then slowly widen your ribs. Good. Make sure the back of the ribcage stays on the floor as you widen. Get my mic a bit closer so I don't feel like I sound like I'm moving further and further away. Now, keeping that dorsiflexion, we're going to start activating more of our legs, remembering that our legs are helping to support our pelvic floor from below. So we want to now feel like you've got 2 marshmallows, one underneath each heel, and you're keeping the dorsiflexion, but now you're going to squish the marshmallows. And then from here, holding that squish of the marshmallows and the drawing back of the foot. So you're just squishing the marshmallows, again, just softly into the floor. So we're not pushing really hard. Think dimmer switch still. Then I'd like you to think about feeling like you want to pull your heels back towards your sit bones, but keep your pelvis neutral. And again, so we're creating an active stretch between the back of our sacrum and our heels. Remember again, dimmer switch. So we're not pulling back so hard that we want to start arching our back off the floor. We're pulling back just so we start to feel that light activation. So we're looking for a light activation of the muscles and the fascia. Holding those 3 things, dorsiflexion, squish, draw back, we're going to do 3 nice slow breaths again and an apnea. So super slow with the breathing, holding everything in place. And just a short apnea again. Focusing on the back of your ribcage being on the floor on the inhale, the back of the ribcage being on the floor on the exhale, and then the back of the ribcage being on the floor as you do your apnea breath. So trying to maintain an even distance between your pelvis and your ribcage throughout the breath cycle. Good. Once you've done that one, we are going to add some more activation. So this one's quite important. We've got our adductors, especially our gracilis, and I've forgotten the name now, my brain's gone again. So our adductors feed straight into the bottom of our pelvic floor. The adductors feed into the bottom of our pelvic floor and then cross across through connective tissue to our obliques on the other side. So if you look at a cadaver and pull the oblique on the right side, the left adductor will twitch.
So we've got this beautiful connection which we can strengthen, which will help to support the pelvic floor by supporting the adductors and the obliques. So as we breathe and do the apnea breath, we are going to be also holding a little bit of an active stretch in the adductors. So we're going to come back to our position, dorsiflexing lightly, squishing our marshmallows, drawing our heels lightly back towards our pelvis. I'd like you to visualize having a small ball between your knees that you're just holding in place. So we're not squishing the ball tight, we're just holding it gently in place. And then you're going to do 3 nice slow breaths and your apnea again, nice and slowly. Inhaling into your ribs, exhaling, allowing it slowly closing the rib cage. So the breath work, trying to exhale for twice the amount of time you inhale for. Holding that active stretching in the legs. Good. And then a little short apnea. Now, keeping that activation in the legs, I'd like you to think about your sacrum growing into the floor and moving towards your heels. And I'd like you to think about the crown of your head moving towards the opposite wall. So we're creating this active stretch from the sacrum all the way through to the crown of the head. As you inhale, I'd like you to think about your ribcage widening. And as you exhale, I'd like you to visualize the sacrum going one way and the head going the other. So you've got that lovely stretch through the spine on each exhale. Okay, so whenever you're ready, you're going to do your 3 nice slow breaths. Everything's staying engaged in your legs as well. You're inhaling, widening your ribcage, and exhaling, actively stretching through that spine. Good. Take your time, 3 nice slow breaths. And then pause. And apnea. Good. At the end of that, we're going to release the legs for a moment. And we're going to come round up to a sitting position briefly to talk about arms. Now we're going to come back down and add the arms in. Okay, so the arms are super important to what we're doing. The more we bring our arms up, the more engagement we get through the serratus, the more engagement we're going to get through our rib cage. So we're going to we're going to think about pre-activating our serratus using our arms, but we're also engaging our big back muscles. Because what we're going to do with our arms is we're going to create an active stretch, and then we're going to rotate them so that we create more of an active stretch. So we're twisting the fascia, which I'm not going to talk about today, but we are going to do it. So that's what we're up to. Then what that's doing is it's starting to activate through our big lat muscles as well. Our big latimus dorsal muscles come all the way down our spine. They merge with our pelvic floor via our glutes. So it's lats, glutes, levator ani muscle. So the more we can get that engagement and strength and flexibility in the lats, the more support we're going to get from our pelvic floor from above. There's lots of other things we're doing, like we're flossing nerves and all sorts of other things with this movement pattern as well. Let's do one arm first so you can feel engagement, and then we'll add the other one. So whichever arm you want, you're going to stretch out towards the side to start with. I'd like you to feel like you want to pull your shoulder blade in towards the center and then allow it to lengthen out towards the side. Good. So we're doing a protraction of the shoulder girdle. Next, I'd like you to feel like reaching out through your little finger or middle finger, whichever finger you want. So we're creating a real stretch and a real opening through the shoulder girdle here. Then what we're going to do is we're going to rotate our wrist. So we're going from the distal end, wrist, elbow, shoulder, in the glenohumeral joint. So I'm not rolling forwards like this, I'm rotating inside the joint. Good. Then, holding that internal rotation, I'm going to bend at the elbow and bring my hand in and place it on top of my thigh. Okay. So I've got extension in my wrist. I'm pressing out through my elbow. I've protracted in my shoulder.
So now you should feel a nice activation happening down that side of your body. Good. Now we're going to take the other hand and do nothing with it except place it on our leg, so just so you can feel the different sides of your body and how different they feel. Okay, let's do both arms. So we're stretching both arms out towards the side. Keep your fingers in your peripheral vision. Good. Pull them together and then protract them out. Rotate your wrist, your elbow, your shoulder. Bend your elbows and place your hands on tops of your thighs. Good. We want to feel like we're gently nudging out through our elbows. Excellent. This is position 1. In this position, our ribcage is closest to our body and our serratus is as least engaged. So it's not really activating through, it is activating, but it's not doing anything really to lift our ribcage too much. Position 2 is when we take our hands and we place them directly in front of our shoulders. So we're keeping the same beautiful shape directly in front of our shoulders. Now in this position here, already our serratus has started to lift our ribcage a little bit more. Keeping that gentle nudge out through the elbows, we're then going to move our hands up into our third position. Now in third position, we want to make sure our ribcage stays over our pelvis in whatever position we're in. And now I'd like you to think about the active stretch coming through the fascia at the back of our body. So I'd like you to think about your stretch coming. It's almost like you're pulling a band from your left buttock all the way up to your right hand. So we're crossing through a really important piece of fascia called the thoracolumbar fascia at the back of our body. So both hands are pulling from opposite bum cheeks, so to speak. Good. This is third position. Now, if your client's trying to get all the way up here and they start to thrust their ribcage forward, they just need to bring their hands forward a bit. Not everybody has shoulder mobility to get here. Some of my clients are all the way down here. It's just their third. We're working with people's bodies. Cool. Shake it off. We're going to add that in on the floor. So coming down onto the floor, we're going to find our neutral pelvis again. Our ribcage heavy. The back of our head heavy. Legs hip distance apart. Gently dorsiflex. Squish our marshmallows. Draw our heels back towards our sacrum, keeping our sacrum nice and grounded. Sacrum moving towards the heels, head moving away from the body. We're going to stretch our hands out towards the side in a downwards V. And then we're going to rotate wrist, elbow, shoulder, and bend our elbows and point our fingertips in towards just in front of the top of our pelvis. So first position. Nice. Good, good, good. Elbows are off the floor, shoulders are wide on the floor, lengthening. Okay, now we're going to do 3 nice slow breaths. Inhale in your joy if you want, exhale out your calm, and then pause and slowly widen your rib cage. Nice. Each time you inhale, think about the rib cage widening. Each time you exhale, think about the rib cage gently closing and that stretch from the sacrum to the crown of the head. And once you've done your 3 breaths in your apnea with your arms in this, which is called first position, we're going to move our hands up to second position, keeping the back of your ribcage, your spine, still that beautiful neutral spine. So second position is directly in front of our shoulders again. So where it was when we were sitting. Feeling that gentle nudge out through the elbows, checking with your feet, your heels, your ankles, your sacrum, your head, your ribs. Then 3 nice slow breaths and an apnea here. So each time we move our arms up, we're creating more of an intense lift through our pelvic floor because we're getting more activation of the serratus and we're drawing our ribcage further away from our pelvis. Take time with your breathing. Remember, the slower you do it, the more activation you get. And then when you're ready from here, you're going to move your hands up above your head. We want to make sure we're moving from the shoulder girdle. We're not using our lats to lift our arms. So we're moving from our shoulder girdle and stretching through the latimus dorsi. You want to make sure the back of your ribcage stays on the floor, which is why I teach this pose here first, because
people can really start to feel where their limitation is with their shoulders to start with. Good. If you're like me and have really hyperflexible shoulders and can get your hands all the way down towards the floor and keep the back of your ribcage on the floor, we're also not doing that. We're going to lift them a little bit off the floor, so we're still working through those chains, because otherwise it's cheating. So 3 nice slow breaths here. Be aware of the back of your ribcage on the floor, on the inhale, exhale, and apnea. Relax your jaw, relax your eyes. Okay, so that's the first pose that I usually teach people. We're now going to bring our whole, this is called, in Hypopressives, we've got different names for the position of the poses in relation to the world around us. So this pose is called a neutral pose. The reason it's called a neutral pose is because the diaphragm is neither being helped by gravity or working against gravity. It's not working as a postural muscle particularly here. So it's quite relaxed, it's much easier to find the pose, the apnea itself, and the breath, and just the proprioception of where our body is. So we're going to come up to standing now and play about with that bit into what's called a loaded pose, because we're working with our ribcage as if it is a postural muscle now as well as a breath muscle. Okay. So, most of the principles remain the same. This is like doing that pose which we just did, which is called Demeter. We're going to come up and do Athena and Venus. So these poses are like the standing version of the pose we just did. So we're going to come to have our feet hip distance apart. We're going to make sure our feet point straight ahead. Now the reason for this is this: we want to be working the pelvic floor evenly. If you angle your heels in, so if you do that and angle your heels in, feel what it does to your body. You feel how it tucks your tailbone under. So what it's doing is, if you think about that pubic diamond shape, it's causing a contraction in the back of the pelvic floor and a stretching in the front. We don't want that. Go the other way, so you're pigeon-toed, and you'll find that you go into a more lordotic pose position. And in this position, the front of the pelvic floor is being squeezed together while the back is being stretched out. So we want to make sure that we're working our pelvic floor evenly to start with, at least. So feet are hip distance apart and straight ahead. Knees are soft. So we're not bending the knees, but we are releasing the quadriceps and releasing the knees. So we don't want to be in this kind of tight knee position that creates this banana boat kind of look, which a lot of my ladies have, because they hang on their quadriceps. So releasing your kneecaps. Making sure that your kneecaps are in line with your second toe, which I know is a cue quite often used in Pilates as well. So from there, we want to find our neutral pelvis. We want to make sure that our ladies are not overly anteriorly tilting or posteriorly tilting in a standing position. You'll have lots of ways that you find neutral pelvis in standing. It might be, there's a really nice one which works for loads of people, where we bend our knees, slide our pelvis forward, and then slowly come back up to standing, keeping the pelvis in that position. And this is really good for people who have a really anterior tilt. The best one that I've found for everybody so far is to think about, it's a bit weird, quite a lot of my cues are a bit weird, is to think about a torch shining directly out of your vagina. So if you think about a torch shining directly out of your vagina, if you are posteriorly tilting, the torch will be shining behind. Anteriorly tilting, the torch will be shining behind you. If you're posteriorly tilting, it'll be shining out in front of you. You don't want to draw attention to your torch, it's shining straight down. This works, for some reason this has just worked really well, I don't know why. So, neutral pelvis, torch shining, soft knees. Next, we want to make sure our rib cage is an even distance away from our pelvis. So if my rib cage was sort of flared forwards, I would have much more distance between my rib cage and my pelvis here, and a much shorter contracted distance at the back. And we want to be working this big transverse muscle the same all the way around.
So if we take our hands around our rib cage and treat our ribs like they're a bell. So we're going to ring our bell forwards first and take a breath and see what where we can breathe in our body. Can you breathe in your abdominals, the front of your chest quite easily, yeah? Can you breathe in the back of your body easily? No. Hopefully not. So we're going to ring our bell backwards into more of a kyphotic spine. Now take a breath. I can breathe into the back of my body, but I'm finding breathing into the front really difficult. And now I've got a much shorter distance here and a much longer distance here at the back. So I'm going to take my bell and I'm going to put it directly over the top of my pelvis. Now take a breath. Can you feel how you get much more movement in the ribs and the body when we're doing this? Much more activation in the transverse. So that's what I'm wanting people to think about most of their lives after they meet me. So the next thing we're going to think about is shoulders. A lot of tension is held in our shoulders. So we're going to just pull our shoulders up towards our ears and just drop them down. I don't want anything else going on with them. Good. Now heads. The head, we want the chin horizontal to the floor. And we want to have the ears directly over the shoulders. So we can either think about drawing the head back, or we can give people a nice visual. So I get them to think about being in a busy restaurant. The couple behind them are talking about something really juicy that they want to know about, but they don't want to tell anybody. So they're going to slowly draw their head back, listening to the conversation without letting anybody know. Good. So, and then eyes nice and soft and looking straight ahead. You have to cue eyes with women a lot. Women tend to look down. I never have to cue eyes with guys, but always have to cue the eyes with ladies. So keeping your eyes looking straight towards your horizon. Life's out there. Then what we're going to do to create the active stretch. So now we're going to look at active stretch creation. Before we do that, actually, let's do 3 breaths in an apnea, not doing any activation yet at all, just in this posture. So you can have your hands around your rib cage or hands by your side. 3 nice slow breaths, and then your apnea. Making sure you're not over-recruiting your shoulders, that the rib cage is widening from the bottom first, like you're filling a vase with water. The vase is filling the bottom, the water is filling the bottom of the vase first, moving to the back of the vase and up to the top of the vase. Yeah, nice and slowly. And at the end of your third one, you're going to pause and slowly widen your rib cage. The apnea may feel harder here. We are now using many more muscles. So we're going to be using our residual oxygen up quicker than we did when we were lying on the floor. We're also using our diaphragm as a postural muscle here. So this pose is called a loaded pose because we're working against gravity. Okay, so now we've got ourselves beautifully lined up. We've had a little practice. I hope it was okay. Now we're going to add some active stretching. What we're going to do is we're going to shift our weight forward onto the balls of our feet, keeping everything else beautifully lined up. It's not a massive movement, and we want to have our toes nice and relaxed. So if we think about a tripod, underneath the base of our big toe, underneath the base of our little toe, underneath our heel. And all we're doing is just shifting forwards that little bit so that we can feel this activation in the posterior chain. If I was to slide backwards, so taking the weight over my heels, keeping my toes on the floor, I'd feel my anterior chain kicking in to stop me from falling over. We're going to shift forward so that posterior chain kicks in. So now we're creating that active stretch through the posterior chain, making sure rib cage, knees are soft, pelvis is neutral. Quite often when people shift forwards, guys, they start to hyperextend through their knees, so we want to make sure the knees stay soft. Okay, from here, we're going to stretch our hands out towards the side, activating the same way we did on the floor and in sitting. We're going to rotate our wrists, our elbows and our shoulders and bend our elbows and bring our hands into first. Same as we did sitting, same as we did on the floor. Yes, I'll show you from the front. Good. Now, 3 nice slow breaths in an apnea. As you inhale, widen your rib cage. As you exhale, think about reaching from your heels all the way up through to the crown of your head, keeping your eyes looking straight ahead. So Wendy, bring your fingers a little bit closer in towards each other. So your hands in a little bit closer towards each other, Wendy. Yeah, that'll feel more comfortable, I think. And Georgia, bring your hands a little bit further away from your body. Yes, good. Nice. And Marie, you can probably separate your fingers a little bit, just give yourself a bit more space across your shoulders. Good. And then from there, we're going to take our hands from this first position up into our second position, directly in front of our shoulders. Again, remembering here that we're just lightly pressing out through the elbows, just very lightly, like hummingbirds holding our elbows and just continuously just tugging a little bit. As we inhale, inhale into your ribs. As you exhale, lengthen through your spine. Vicky, bring your hands a little bit further apart. You'll feel quite contracted across your shoulders there. That's it. Yes. Good, and then from there you're going to take your hands, when you're ready, you're going to take your hands up towards your third position, keeping your rib cage directly over your pelvis. Nice, guys, these look good. When you come here, I'd like you to think about the stretch coming from underneath your right foot all the way up through the back of your body, across through the thoracolumbar fascia. So it's come all the way up here, across the thoracolumbar fascia, and then up to this hand up here. So we've got a stretch that goes the whole way through. Remembering the ribcage is still over the pelvis, we haven't thrusted the ribcage forwards or tucked the ribcage back. 3 nice slow breaths. We're going to pause for questions in a moment, but we're going to do the other arm position first as well. Now, why do I say kind of shoulder distance away from each other with the hands and things? What I'd like you to do now is I'd like you to take your hands into second position. I'd like you just to cross them across so you can feel what starts to happen. You feel how you start to get this tension here in the neck and in this top rib and the clavicle. Now, if you separate them really, really wide, you feel how your shoulder blades start to retract. So we want to be at the point where our shoulder blades are nice and protracted and our chest is nice and open. Everybody's slightly different because arm sizes, you know, body sizes are different. Anyway, so just getting that feel of where that is in your body. Now, a lot of people come to me and they're already very much in this position. And as much as it would be great to just be able to teach them this and then rotate and they'd be able to pop out that position, it's usually not likely. So we have another arm position that I introduce people to, which is our external rotation. So we're doing the same thing. It's the position we started in. So we're going to stretch our hands out towards the side, palms face forwards, thumbs up towards the ceiling. So they're not rotating all the way over, thumbs towards the ceiling. We're reaching both hands out towards the side. Feet hip distance apart, knees soft. Feet pointing straight ahead, neutral pelvis, rib cage on top of your pelvis, head on top of your shoulders. Shift your weight forward onto the balls of your feet. Keep your toes nice and soft and relaxed. Look straight ahead and wiggle your fingers so you can see them in your peripheral vision. We want to make sure we're not locking the elbows out. This is especially important with working with hypermobile ladies, where it's almost like we're just about to come in for a hug. Okay, now here, reaching out through that little finger, 3 nice slow breaths and an apnea. Good. So it's in a low V to start with. Yeah, good. We're going to go low V, T, high V. Nice, Emma. These look nice. Each time you exhale, you want to think about getting just a little bit taller. And you're never going to release that height. When you come for the inhale, you're just going to get continually taller. And when you're ready, you're going to take them to your T. So it's just a move up. Good. In the T, same thing. Peripheral vision for your fingertips. Reaching out through your little finger. Soft elbows, they're not hyperextending at all. Knees are soft, neutral pelvis, rib cage an equal distance away from the pelvis and stacked, head stacked. And each time you exhale, you're getting just a little bit taller. Good. Then from here we come up to our high V, and our high V in our high V position, that stretch is coming from the back of our heels. So we're not using our shoulders to reach up with. We're using our latissimus dorsi, our serratus, our glutes, our hamstrings, all the way through our body, our heels, and same on the other side. So this is a full body activation. Soft knees, relaxed jaw, Annoying barking dog. Good. And shake it off. Questions? How was that for you with the apnea? What did that feel like in your bodies?
I feel it's getting quite tight in my neck after a while. Is that meant to be? Is the fascia meant to be working there, or am I just holding?
The fascia is meant to be working there, but I think you might be holding too tight.
Yeah,
so
maybe.
I'll get you to swivel around to the side in a minute, Wendy, and have a look at your posture when you come into it, because you seem quite far forward when you were doing it.
Okay.
So I wonder if what's happening is that you're bringing yourself so far forward that your head is having to really work. You know, so you want to take it forward so it's just like a dimmer switch coming on with that posterior chain as well. You had quite a massive lean, so I was waiting to see what you said. So it is, people do over try with the lean. The lean is not massive. The lean is just, again, like that little active stretch. Yeah, I'll have a look at it from the side in a minute. I'm going to get everybody to turn to the side in a minute. So, any other?
Yeah, my observation is, you know, lying on my back doing it all, I seem to sort of have it, and standing up though, it's much tougher for me, all of it. Just the breath control. I can feel one side of the rib cage expanding differently to the other, whereas it was quite symmetrical when I was lying down, really, in the end. So yeah.
Yeah, it's a lot harder when we come to standing. Standing because we're working against gravity and all sorts of other things start to come into play. All your postural imbalances, because once we put the body in and line the body up and get everything ready, you know, now there's no place for them to hide. So you'll start to feel things, tight things being tighter, and yeah. But it should all start to, and also this has been quite quick. Usually with people, they'd have a whole week to practice lying down, and then they'd come and they'd see me and we'd do sitting and quadruped, and they'd only see the standing in the third week. So they'd have had a huge amount of time to practice.
Can I ask a question, Abby,
Yes.
or also observation?
Yes.
So with each different arm position, and that was supine and standing, I felt that I could get more rib expansion.
Yeah.
And then the higher the arms, rib expansion, and then there was more sort of stuff going on lower down.
Yes, we're getting more of if you think about we're getting more of a visceral traction as our arms move up, because we're getting more engagement through the serratus, and we're getting just more engagement through the thoracic area. And we're getting more through engagement. There's as the arms go up, we are getting a more intense stretch than we get in any of the other poses.
So that's what I was feeling. So wonderful. Thank you.
That's okay. So the overhead hands are the hardest for a lot of people, and quite often they're the hardest for people to feel, because what's happening is that once we bring our arms up, our rib cage is already pretty activated. So the more mobile your ribs get, and the more you get into this, the more activation you'll feel up here. But initially it's like, okay, my ribs are open as far as they're going to open. They're not going to open anymore. The other thing is that we're using up much more residual oxygen as our arms come up, because we're using many more muscle chains and muscle connections and fascia connections. So we'll run out of air quicker, or run out of residual oxygen quicker when we do the apnea. So that's another thing that quite often happens with people. Okay, good question. Any more?
Yeah, I found with lying down, the apnea breath, just I could feel the ribs opening, and in standing I was sucking the base of my throat down into behind my ribs, and I didn't know if that was a bit different.
So that's part of it. So that's the esophagus connection to the diaphragm. So as the diaphragm's pulling down, the esophagus pulls down with it. So it's a good way to tell if people don't want to take their clothes off and show you their apnea. A good way to tell they're getting the apnea is as they start to do the apnea, you start to get these big indentations in here. And so it's a nice way to tell. When I learned in Spain, they made us do it in bikinis, which I wasn't very happy about at like 9 months postpartum. However, if I asked any of my Scottish ladies to do that, nobody would have ever come to classes. So there's other ways to check. Yeah, and one of them is to look in the neck. So what you're feeling is that if it gets too intense, what you can do is just move your neck from side to side to release some of the build-up of suction.
Okay, great.
Everybody else okay? Okay. We're
Uh,
gonna
Sorry, when I was standing, I found I was really trying to over-recruit my abdominals when I was doing the apnea breath. And I found that in standing, much harder to release the abdominals.
Yeah, so it comes with practice. So I also, in order to get a much better rib opening and standing, because you already got quite a lot of activation happening, I do have to do that cue of releasing the abdominals a little during the pause before the apnea, and then widen.
Yeah.
And it's working out how much to release, because we don't want to just let it all hang out, and it's kind of personal to everybody. So I reckon, you know, if you can manage to think about 20%, then that's how much you is kind of optimal for most people. But the standing pose is incredibly difficult. The next pose is going to be easier, I hope. Yeah. Sally, did you have a question?
Yeah, well, a while ago you mentioned the tone of the fascia.
Yes.
And I'm not that hot on my anatomy, but tell me, I didn't know that you could have tone in your fascia.
So your fascia can be dry, so it's more about moistening it so it's flexible and movable. So the tone comes from how moist it is and how mobile it is and how flexible it is. So,
okay.
Yeah, so fascia is predominantly can be dry and stuck and hard and soft and moist and malleable. And the tone in the fascia we're talking about is that soft, malleable tone rather than that. And in the fascia, it speaks predominantly about dry and moist. Yeah.
Got it. Thank you.
Yeah. Okay. So, and the more moist it is, the more electrical impulses your nerves will be able to put through it. So the more sensation you'll get and the more activation you'll get as well. So that's the other big thing about fascia. So one of them, there's loads. So we're going to come to the hip hinge position, which is the least well done position in the whole wide world. I have an amazing trainer. I've got lots of amazing trainers, but I have an amazing trainer called Kirsty, and this is hers. I always attribute my nicked stuff to the people I nick it from. So this is from Kirsty. So what she gets her clients to do, she gets them to imagine that she gets them in their beautiful alignment we just learned, which we'll go through again. She gets them to imagine they've got a drawer behind them and a basket of washing in front of them. And then she gets them to shut the drawer with her bottom, with their bottoms, while keeping the washing upright. And then from here, we've got our nice chest, we've got our beautiful neutral spine, we've opened our glutes, and now we just take our hands and place them on the tops of our thighs and make sure we've shifted our weight forward onto the balls of our feet. That's it. The big thing with going into this hip hinge position is that a lot of women are holding posture patterns. The biggest one that people hold is their body starts to instinctively pull their bottom under, and they try and they lose their lordosis in their spine. They get this really flat spine, and they get these really tense glutes that are overworked, trying to desperately hold their pelvic floor in place. So this kind of posterior tilt, lordotic spine, is then when they come into a hip hinge position, they're holding so tight, and this feels normal, that they try to come into the hip hinge position and it becomes like this. So there's no expansion in the glutes here. And what we're looking for is that extension in the glutes, to do that stretch of the levita ani, to stretch the lats and all of this. So we want to find a way to release here. The other posture pattern which really affects this is this one, but this one quite often is coupled with the upper rib gripper. So the upper rib gripper is trying to pull up everything from the ribs. So the ribs collapse in, they're tight here, and they come into this kyphotic spine. This is usually coupled with the bum grippers as well. And you start looking at people in the street and you start to recognise all these posture patterns that are just like, oh, I'd have trouble with her doing this. And so once we get them beautifully lined up, we know that they're not gripping with their glutes anymore, and we don't want them to go into a grip pattern. So giving them something else to think about is really good. So we're all going to come up and try this out. So feet hip distance apart, knees soft, neutral pelvis, ribcage stacked, shoulders relaxed, chin horizontal to the floor, eyes soft, gazing ahead. Washing basket, open drawer, shut the open drawer. So we're not coming into a squat, we're just shutting the draw. And then we're going to put our hands on the tops of our thighs, and we're going to make sure our ears are still in line with our shoulders, and our chin is still kind of in line with our chest. So we're making sure we're not contracting through the back by extending. Okay, good look at you all. Now here, shift the weight forward onto the balls of your feet. Make sure that your thumbs aren't coming around the outside of your legs because it'll get sore eventually in the ligaments. Good. Now, three nice slow breaths and an apnea here. So Jyoti, rotate your arms around a little bit more so elbows are pushing out towards the side. Good. Wendy, come out of your squat. So we're not squatting down. So this is a big thing. So the minute we come into a hip hinge, quite often we get this sitting down. So we want to just release the glutes. So my legs haven't changed. It's just the orientation. It's like a deadlift. And then three nice slow breaths from an apnea there. So Sally, release those glutes a little bit more. Your glutes are quite contracted. So think about opening them. Yes, much better. Really good. And Caroline, release your glutes a little bit more. Good. And Wendy, look down to the floor a little bit more so you're not contracting through the back. Yes, perfect. Good. And Sue, make sure you're not squatting too much with those knees. So you want to come up, so knees are almost straight, so they're just soft. It's just a hip hinge. So we're not sitting back, knees are not bending, knees are just staying soft. Yeah, that's better. Good, good. Excellent. So the last thing about this pose is now that we've got this kind of worked out, that our knees are staying where they are, our pelvis is pressing up behind us, we're shifting our weight forward, we put our hands on the tops of our thighs, internally rotated. We're now going to think about pressing lightly out through our elbows. We're making sure that our head is in line with our shoulders. She usually gaze is about 1 meter in front of us. It's usually right for most people. Toes are relaxed, weight shifted forward, sit bones are wide. Good. So think about the elbows next. Good. I meant to get you to stand to the side. Yes. Good. So think about your necks. You want your neck nice and long, no contractions. Internally rotate your hands, palms, so fingers pointing in towards each other, so you can have that elbows pressing out towards the sides. Good. You can place your hands on your thighs and you can put a little bit of pressure through them to help support your back as well. Good. How did that feel in your bodies, guys?
It's like a hammock feeling right underneath the glutes. It's like your glutes are just stretching and then you get this like big hammock feeling. Again,
Yes.
that's what I was feeling. Nice
Yeah.
fit and length. Yeah, through the spine. It's lovely.
Yeah, it's a really lovely stretch for that posterior chain. And that opening of the glutes is really important for most women, to be honest. Anything else you're feeling in your body?
Well,
Sue?
I could really feel my hamstrings working much more. Should they be, or am I doing something wrong?
Yeah, they're part of that posterior chain, so they should be really working as well. So
Yeah, they were.
yeah, so your glutes go into your left tummy, but they also merge into the hamstrings as well.
Yeah,
So
yeah.
for a continuous stretch, yeah.
I like the back, just that back line of the body in that position, which is nicer than for me working in prone, which is too much often, but that is just a really nice engagement on that back line.
So it's lots of people's favourite and some people's most hated pose. So there's lots of, I used to say this pose makes you feel amazing, but I stopped doing that because everybody's got different poses they like the most. So yeah, we use them all.
I just felt like almost like a warmth coming all the way up the back of my body. It was really nice. It was just really lovely feeling that everything was just almost melting, I suppose.
Good. So this is really important for people who are hypertonic through their pelvic floor as well, for another reason. Because as we go into the hip hinge position, our femurs change their position slightly. So as we hip hinge, our femurs roll in slightly. So they roll in. As they roll in, our sit bones push out. So we're widening in the pelvic floor. Our sit bones push out and our ASAS bones at the top draw in, giving us more space in this transverse to expand the rib cage. So a lot of people feel a better rib opening in this position because we've put ourselves in a position where we've got a lot more ability to be able to stretch the muscles to help engage. When we start to open the rib cage, we've got more give in the muscles, so to speak. But at the same time, because we've rolled in, we've taught people how to stretch the glutes so they're not fighting the rolling in of the femur. Then at this stage, we've also got this beautiful stretch all the way into the left to Annie, which is what you're feeling there, Alison. Is that connection all the way through? Yeah.
I get my clients to do this every week. Oops, sorry, I've got something on my screen. We call it the waiter's bow. I don't know if anyone else calls it the waiter's bow. We do this not for pelvic floor stuff, but just I tell them to nudge the door shut with the bottom. And I always just, the first time I always just get them to check the shin bones vertical, and that's it. And then it takes them away from the squat. And it's just a different kind of thing from a squat because it works different muscles, but it works really well. So if it does work the pelvic floor at the same time, it's quite handy.
Yeah, it really does. I mean, that's why deadlifts are so good for women to do as well. They're weight bearing, and it's the same position for a deadlift. It's exactly the same position. Yeah. So these are, I mean, they're common things that go across different disciplines because they're really good for us, you know. In hypopressives, it's not waiter's bow, but it's called Artemis. And Artemis is an unloaded position. So this, loaded, working against gravity as a postural muscle. This, unloaded, because we're getting help from gravity. It's also as extra information for women who come to me and say, what do I do when I'm coughing? Because coughing puts such a lot of pressure on our body. If we lean forward a little when we're coughing, the pressure, it's like it's running down a hill. You know, so instead of falling